Good afternoon, everybody. It is my great pleasure to welcome you all on board on the 4th ENS Peripheral Nerve Surgery section webinar regarding foot drop etiology, diagnostic workup, and indications for treatment. It is my great pleasure to co-chair this webinar with Dr. Deborah Garozzo, who organized this webinar, creating the program, scientific program and scientific contact. And I hope all of you enjoy and have some benefits until this morning. More than 400 registration participants are for this webinar. So we are live online now, and we can start with the webinar. I will leave the floor to my co-chairman and host of this webinar, Dr. Deborah Garozzo, to start with the webinar and to run this webinar through the introduction and following the topics. I would just would like to announce that I will, in a first discussion period, make some presentation of 3 minutes presentation of one case, a foot drop case, which will be, I would say, beneficial for discussion.
Okay, so first of all, let me say thank you to all the participants and especially to the speakers for accepting my invitation to take part in this meeting. And of course, a great thank you to Lucas, that is always extremely supportive for every initiative. And then I also would like to say thank you to Anna, because she has done a great job in trying to put the logistic part of that. Now, the reason why I thought that it might be interesting to have a webinar on foot drop is that actually this is probably one of the most frequent occurrences that you can see in your neurosurgical practice. And in my attempts, my constant efforts to try to prove that peripheral nerve surgery should not be considered like a branch completely detached from the rest of neurosurgery, I thought this might be, let's say, a kind of general topic that might probably trigger the interest of the neurosurgeons that are usually not very much into peripheral nerve surgery. So I think we are going to do an overview of all the aspects of this kind of pathology. I think it's my great pleasure to have here some friends from not only Europe, but also from other parts of the world. So I would like to say a big welcome and thank you so much for accepting to participate to Leandro Preto Flores, that has always been an amazing neurosurgeon dedicated to peripheral nerve surgery, and also to my friend Mohammed Reza that is connected from Iran. So the first presentation is going to be about anatomy, and I have the pleasure to introduce Dr. Crescenzo Capone from Italy. He is going to talk about anatomy. Thank you. Crescenzo, please start.
Yes, I'm joining the... Can you see my screen?
Not yet.
So you should see it right now.
It's perfect.
Yeah, it's okay.
Great. Well, thank you very much for the presentation. It's great to join our online meeting again. I have to say thank you to Deborah Garozzo from the ENS for inviting me, and also for the terrific organization of this webinar. Before we analyze the clinical surgical features of the foot drop, it's, in my opinion, important to summarize the main anatomical and functional characteristic. By definition, foot drop is the impaired ability to perform dorsiflexion, namely the raise of the toes or raise of the foot from the ankle. This can be due to nerve weakness, irritation, or damage to mostly the common peroneal nerve, or the paralysis of the muscle in the anterior portion of the lower leg. Foot drop may be temporary or permanent, depending on the extent of the lesion, and it can occur in one of both feet, leading to the typical steppage gait. Important to remark, foot drop is not a disease itself, but rather a sign of an underlying pathological process. The causes of foot drop should be discussed using a localization-focused approach before we consider the etiology. Even if sometimes caused by a muscular impairment or non-function, foot drop is usually a result of an injury to any point of the nervous pathway that leads to the extensor muscle in the anterior compartment of the leg. Of course, it can be central, so from brain or spinal cord, or related to the peripheral nerve. The journey of the motor neurons who are direct to the tibialis anterior muscle start from the lumbosacral plexus. The nerve roots from L4 to S3 branch out in the posterior pelvic region. Then the nervous bundle from the common peroneal nerve joins the tibial bundle and form a long, thick nerve that goes downward. That is the sciatic nerve. The sciatic nerve passes between the muscles piriformis and through the gritty sciatic foramen, quitting the pelvis. From here, it travels down from the posterior compartment of the thigh, passing behind the muscle adductor magnus and in front of the long head of the muscle biceps femoris, reaching the popliteal fossa. At this level, just above the knee, the sciatic nerve divides into its two branches. The tibial nerve, which travels down the posterior compartment of the leg, and the common peripheral nerve, which travels down the anterior and the lateral compartment of the leg. This latter is the main actor, can be considered the main actor in the pathological mechanisms of foot drop. Therefore, now we will focus its attention on it. From the superior angle of the popliteal fossa, the CPN travels around the neck of the fibula, then divides into its terminal branches, the superficial and the deep peroneal nerve. Anyway, before splitting, the CPN provides a lot of cutaneous and articular branches who are directed to the popliteal fossa and the joint of the knee. The first branch, the deep peroneal nerve, begins at the lateral side of fibula, then enters the anterior compartment by piercing the anterior intermuscular septum. At distally, it follows the course. It takes first a relation to the anterior tibial artery, then follows it until the ankle joint, where it divides into lateral and the medial terminal branch. The DPN can be considered the analogous to the posterior interosseous nerve in the arm. In the same way, in the leg, the DPN supplies the branches for the extensor muscles of the leg, such as the tibialis anterior, who is the biggest and largest dorsiflector of the ankle and of the foot, the extensor digitorum longus, the peroneal sterchus, the extensus hallucis longus, and an articular branch directed to the ankle joint. Anyway, after bifurcating, the lateral branch of the deep peroneal nerve innervates also the muscle extensor digitorum brevis and the extensor hallucis brevis, who, as the name says, are directed to the finger and the toe. The other terminal branch of the CPN is the superior peroneal nerve. It is the main nerve of the lateral compartment of the leg. It begins at the lateral side of the neck of the fibula and runs through the perineal muscles, then reach the extensor digitorum longus under the deep fascia of the leg. This nerve innervates the muscle peroneus longus and the peroneus brevis, and innervates the skin over the atrolateral aspect of the leg. Clinically, a damage to the deep peroneal nerve is the most common isolated mononeuropathy of the lower extremity and always results in foot drop. The most common cause of damage are related to knee traumas, motor neuron disease, diabetes, ischemia, infectious, and inflammatory conditions. On the other hand, an injury of the superficial peroneal nerve can result of the inability to avert the foot and the loss of sensation of the dorsum. As a final remark, it's important to briefly mention that foot drop can be caused any way down the path, from the brain down to the foot. Anyway, there are some typical weak points and conditions that a neurosurgeon should keep in mind and consider as in first instance, when facing a patient with a foot drop. All these weak points and conditions will be widely discussed in the next presentation. Thank you very much for your attention and enjoy the rest of the webinar.
I would like to say thank you to Crescenzo, because this was an exhaustive, but at the same time, not boring at all, anatomical presentation, which is actually something that we have to admit sometimes happens. So
I try to make my best.
It was really well done. Thank you so much. Now, the next speaker I have the pleasure to introduce is Dr. Mohammad Reza Hemamadi from Iran, who's going to talk about the clinical presentation of foot drop. Clinical presentation and management. So please, Mohammad Reza, I think you are sharing your screen.
Do you have my screen?
Yes, we see it.
I can't. Okay. Thank you and good evening, my colleagues. I'm talking about the foot drop and clinical presentation. Foot drop is a gait abnormality due to the paralysis or weakness of the foot and ankle dorsiflexor muscles. This dorsiflexor muscles is tibialis anterior, extensor hallucis longus, and extensor digitorum longus. Before I explain the presentation of the foot drop, it's necessary to review the gait cycle. In normal walking, there is two phases. One is a stance phase, when one foot is bearing all of the body weight, and swing phase, when one foot is not touching the walking phase. As you see in the figures, the dorsiflexor are active in swing phase and early stance. So in paralysis or weakness of this muscle, foot cannot be lifted off the ground during the swing phase, which is we will see in the foot drop. There is some causes of the foot drop, neurological or muscular, and in neurological, peripheral or central, and I explained the clinical presentation. Foot drop symptoms based on the specific nerve compression. The symptom of the foot drop may occur gradually or appear suddenly and vary depend on the type and severity of the underlying disease. Some lesions which is around below the knee, I mean below the fibular head, is divided to common peroneal nerve palsy, which deep and superficial peroneal nerve are involved. The patient cannot unable to dorsiflexion and eversion, sensory deficit on the dorsum of the foot. Sometimes isolated deep peroneal nerve injury. So unable to dorsiflexion, but eversion is preserved, and sensory deficit in the first web, and is sometimes injury to the extensor hallucis longus branch, which names is drop hallux. In drop hallux, you see that on the extensor hallucis longus does not dorsiflex the hallux. Drop hallux is not as debilitating as drop foot, but it's troubling, especially when walking barefoot. Sometimes in sciatic nerve injury, there is foot drop that may mimic a common peroneal neuropathy at the knee, but it is along with difficulty in ankle plantar flexion and toe flexion, loss of sensation in the sole and dorsum of the sole, foot, and the lower leg, muscle atrophy, hamstring weakness, and decreased ankle reflex. Foot drop may also we'll see in lumbosacral plexopathy. In traumatic lumbosacral plexopathy typically causes palsy in the distribution of the common peroneal nerve and gluteal, tibial, or obturator nerve. There is also an acute foot drop, which is intrapartum lumbar plexopathy, which the fetus head can against the pelvic rim, and acute foot drop will occur. Differentiation between L5 radiculopathy and perennial nerve lesion is very important because it is a challenging clinically. As we know that both of these processes present with weakness of the foot dorsiflexion and toe extensor. But tibialis posterior muscle is a primary ankle inverter, is supplied by L5 through the tibial nerve, so will be spared in a common perennial nerve lesion, but it will be involved in an L5 radiculopathy. So in L5 radiculopathy, weakness of the ankle inversion we have. How about the sensory loss? Sensory loss is typically found over the lateral leg and dorsum of the foot, spanning the fifth foot in neuropathy. But sensory is not reliable because there is some overlap between dermatomal pattern and peripheral nerve distribution will occur, and so it is not, some sensory evaluation may be prone to the subjective bias. Decrease in the reflex is also important, and it's in the favor of the L5 radiculopathy. Vesting of the extensor digitorum brevis and also pain may be another sign of the L5 radiculopathy. What is very important and should be considered is the central foot drop, which origin is the brain and the spinal cord. Certain cases, till present, certain cases with sudden foot drop of brain origin have been reported. One of these is infarction in the anterior cerebral artery. In this case, foot drop is without sensory deficit. We should find the presence of the Babinski sign in brain mass, special parasagittal tumor. Foot drop with the spinal cord injury can be associated with the broad spectrum of the deficit, such as motor deficit, sensory deficit, and also autonomic deficit. Charcot-Marie-Tooth is a neuropathy that very frequently is accompanied with foot drop and sensory loss. A triad of the muscle atrophy, high arc, and claw toes are signs of the this genetic disease. Sensory and proprioceptive nerve is damaged, but unmyelinated pain nerve are intact. Sometimes in early symptom of foot drop are usually subtle. This is warning sign. In milder case of foot dorsiflexion weakness are assessed with walking and manual muscle testing. What is important is the walking pattern or gait changes to compensate for the weakness in the foot muscle. And what is this warning sign? You see that high steppage gait is a abnormality in this gait due to the foot drop. On attempt of heel strike, the toes drop on the ground. To prevent this, the patient flexes the hip and knee extensively to raise the foot and slap it on the floor forcibly. Another gait, circumduction gait. In this pattern, the leg remains straight and swing to the side in a semicircle to move forward. Hip and lower limb rotate outward. A slap gait. The foot drop can be subtle, as I mentioned before, often noticed by patient hearing the foot slap on the ground during walking because the weakness of the ankle dorsiflexor in the early stance phase of the walking. Another one is tripping and falling. It is common to lose balance, tripping and falling with a foot drop. It may be intermittently and repeatedly. Fall occurs due to inability to properly lift the front part of the foot and toes when walking. And inability to hold the footwear, a feeling of losing of the footwear or slippers may cause discomfort and dragging of the affected foot during walking. And what is especially in the foot drop in children is a limp foot. The affected foot may flop away from the body, and she or he is difficult to climbing the stairs. There is other cause of the limp is weakness, deformity, and also pain. And about the management, there are two management: is a conservative management or surgical management. Conservative management, the goal is to prevention the deformity and improve the gait through one, splintage, exercise, and electrical stimulation of the muscle. About the splintage, one of the most popular is ankle for foot orthosis, or AFO. AFO provide toe dorsiflexion during swing phase and stability at the ankle during a stance phase, and pushing off stimulation during the late stance. There are two types of AFO that the patient should wear. One is nighttime AFO. In nighttime AFO, the splint, the knee is in 20 degrees of flexion, as you see here, this one, and ankle is in 19 degrees. But the other is AFO in shoe. The device allows walking in the daytime, that he can put it in the shoe and easily walking. And electrical stimulation is for preventing muscle atrophy in the degenerated area. And at the last things is independent of surgical or conservative approach, every patient with foot drop should undergo training. And therapeutic goal is to reduce the muscle fiber atrophy, to preserve ankle mobility, to promote reinnervation after nerve transfer and accurate central control after tendon transfer, and also to improve the gait. Thank you very much.
Thank you so much. Thank you so much for this presentation. That was definitely comprehensive and gave us, I would say, a complete overview of the causes of foot drop, and not only for peripheral nerve surgery. So we go on, and now we are going to have the presentation by Maria Pedro from Germany. Dr. Pedro is going to talk about the diagnostic workup, and especially she will focus on the role of imaging and electrodiagnostic studies. Maria, please.
Thank you, Deborah. Thank you, Lucas, for inviting me. So Deborah just gave me 10 minutes, so let's hurry up with the topic. As we already heard, the diagnostic is essential, but it's just one piece in your complete workup. So first of all, you have to talk to the patient, you have the clinical examination, and then you have to think which diagnostic tool you would like to have. So do you prefer looking into the nerve in a high resolution? So probably would make sense to make a magnetic resonance neurography on ultrasound, or a normal MRI would be sufficient. So I will concentrate not on the herniation of the lumbar disc, I will concentrate on the peripheral nerves, and we have those three pillars concerning entrapment syndrome, traumatic lesions, also iatrogenic lesions, and peripheral nerve tumors. So, and I decided to show you some cases because I think this is the most important thing. Electrophysiology is essential, no doubt about that, because MRI and morphology, but you need to have also information about function. So first of all, I would like to start with the classic recent case of an entrapment syndrome of the peroneal nerve. So it's a healthy male, 57 years old, no medical history, but he likes to do some sports and he likes to walk, he likes to jog, and he had no trauma at all at his left knee, but is suffering of real pain and it's really disturbing him. Neurologically, he has no deficit, so he has a complete normal motoric function, a positive tinal sign to electrophysiology. The unsymptomatic right knee is even worse than the left one, so ENG is normal. So in this part, we don't have anything really pathologic. Now I brought you kind of normal MRI. It's a turbo spin echo on the left nerve and on the right side the perineal nerve. So blue arrow is the tibial nerve, the red arrow is the perineal nerve, and you see on the right the perineal nerve is kind of normal looking, but he's really squeezed and stretched somehow, but his signal is kind of normal. Coming up to ultrasound, he's a thin person. I decided to do an ultrasound, and proximally, you always take around the area, the circumferential area. It was 0.07 square centimeters, so it's kind of normal. You see the fascicular structure, and going more distally, you see the same you saw in the MRI. It's really flattened, stretched, but you see the Rome. It's really important because ultrasound, and this is one of the take-home message, the red flag, normally on an entrapment syndrome, you have a swelling before the entrapment. This is what you see in ultrasound. So you see swollen, big area, and it should be 1 to 2 if you have to visualize it and to measure it up. So in this case, I will offer him surgery, but morphology and function is quite normal, but he's really suffering and he's not able to do his sports anymore. And so I decided to go for surgery, but I still have to do it. So we can discuss it later on. Coming to a very, very important topic, those are the traumatic nerve lesions. And this is another case, recent case, kind of stupid accident, to be honest. A 22-year-old male just decided to get drunk at home with some friends, and he simply fell from the couch and distorted his left knee. You see on the right side the scars. He ruptured his ligament and the meniscus, and he had no function at all of the perineal nerve, nothing. No motoric function, no sensory, and the EMG revealed no compound muscle action potentials, no nerve conduction velocity at all. And here is an MR neurography. We perform it at the university nearby in Würzburg by Professor Farm. And you see again, blue arrow, the tibial nerve, and on the right side in red, you see a white nerve. And this is what the morphology of neurography you see. So we have a 3 Tesla, a fat saturation, space stir sequence, and you see a bright, hyper-intense lesion of the nerve. And then you would say, okay, this is what I expect. I'm distally, I'm not at the sciatic level. But going more proximally, what you see is actually small white dots on the perineal nerve. Again, on the left side, you see the tibial nerve, and on the right side, those white little dots. So we have to suppose that the nerve is stretched, distorted about a higher level, much more what you would expect. So I performed an ultrasound, and I take the ultrasound machine into the OR because I want to know where to cut, where are my incisions, where's the lesion, I suppose. And here you see the intraoperative ultrasound. Again, on the left side, you see the fascicles of the tibial nerve. So I'm on the tide. And on the right side, you see a black hole, hypoechoic, no fascicles. This is the perineal nerve. And this is what we say it's a neuroma in continuity. Again, this was morphology. Coming up to intraoperative electrophysiology. those nerve actions potentials. There was no signal at all, so I went for nerve grafting, about a distance of 13 centimeters. But this is what you see: fascicles on the tibial side and a perineal nerve, a black hypoechoic hole. Again, some take-home messages. In summary, traumatic nerve lesions. Take an MRI if you can, an MR neurography. Take a look about screws. This is another case. You see the denervated muscle, you see the screw, you see again blue arrow, the tibial nerve, and the white dots of the perineal nerve. And again, ultrasound, right side tibial nerve, black hole, hypoechoic in nerve ultrasound. This is the typical finding of neuroma in continuity. Coming up to peripheral nerve tumors, again, another case, 32 years, male, completely healthy. In 2014, he noticed a simple lump, nothing more, a little bit radiating. He did not go to the doctor. Then 1 year later, a sudden deterioration of his function. He really had only 1 out of 5 for the tibial anterior. And I thought after this MRI, okay, this is a schwannoma, probably a neurofibroma. Went for surgery. It was, for me, kind of normal. I was thinking intraoperative of a schwannoma too, but later on I was wrong. It was an FT. Then we later on performed FDG PET, and we, after discussion, we resected the perineal nerve about 50 centimeters. He then went quite well, but he developed a metastasis of his lymph node. He got chemotherapy, but he's still alive, another control. But this is what I say, MRI, not really special, but the clinical sudden deterioration was very important. And if you think of this MRI and then another case, again male, again on his tide, only a little bit of a tinal sign, but without neurological deficits. And this is also a very important part of peripheral nerve tumors. At a German university nearby, the orthopedic surgeons decided to go and take a biopsy out of it. They got to know that this was a schwannoma. They decided to operate it themselves, and in white margins, and you can imagine what happened. Tumor is out, but the nerval function also. And this was the point when he then came to us and we performed nerve grafting. But this MRI kind of looks more suspicious. You see a cystic formation, it's bigger, but this was a schwannoma. And the big difference is the clinical. You see the first case, clinical sudden deterioration, and he not. Coming just a little, some slides to cystic formations, Nora is telling you later on more. You see an MRI, no lumbar disc herniation, this female completely healthy, but she has some problems with anxiety. She had some paresthesia, then a paresis. She had intense formation. This is an intraneural cystic formation. Then another case of extraneural formations. And I brought you on the right side, you see the neurosonography. And at this point, at the end of the film, where the perineal nerve red arrow is really next to the cystic formation, I was not quite sure if this could not be a combination of extra and intraneural ganglion cysts, but it was just operated her and just extraneural. But sometimes ultrasound is difficult to interpret. It's not always easy. And I also used in this case the intraoperative ultrasound just to get sure that I got all the cystic formations because it was huge. So I use it for my control during surgery. At the end, as a summary, it's take-home messages. What you expect concerning the entrapment syndromes and using ultrasound think of the swelling of the pseudoneuroma. And concerning trauma, I would really recommend to do an MR neurography so that you get a look into the nerve, so that you see the extension, the lesion you expect. You can use it for your incision planning. Combine it, please, with nerve action potentials. Tumors MRI is the gold standard, no doubt about that. And concerning ganglion cysts, sometimes ultrasound is nice to have, but sometimes it's even difficult to distinguish between intra and extra ganglion cystic formation. And last slide, while I was preparing my presentation, I just found this beautiful work from Rome, quite recent, and you can combine electrophysiology and ultrasound. Think of lesions where you have an atrophic muscle and anatomy is simply not as it used to be, and sometimes ultrasound may help you to needles better positions and to get better results out of it. So thank you for your attention.
Thank you so much, Maria. Excellent presentation as usual. I have to say we have come to the first discussion of this webinar, and let me tell you that I'd like to congratulate with all the speakers, because each of you has provided really very comprehensive and at the same time concise presentations about the topics requested. So we can open now for discussion. I think, Lucas, you said that you had a few slides about a case you wanted to.
Yes, Deborah, thank you. I would like to share my screen for a few slides. This is, I didn't want to present anything, but somehow it appears that I operate the patient on Monday, 2 days ago, with a nice case which can be stimulating for discussion. Just to, you can see my screen now, yes. We can be stimulated for discussion. So it is, patient is admitted to our hospital on Friday, last Friday, for a foot drop without no, let's say, clear reason. So it's 17 years old patient, no previous diseases, no family history of any neurological diseases. Long time ago, familiar history of diabetes type 1. Both grandmothers have some type of diabetes, but parents does not. And 5 weeks ago, after waking up, spontaneously right foot drop. No report of trauma, without signs of spontaneous recovery. It is how it works.
Okay, stand on your toes.
MMT for dorsal flexion on right foot 0 to 5.
Now stand on your heels.
Slight numbness in the skin region innervated by the superficial peroneal nerve on the right side, but no real sensory deficit. So you can see foot drop is complete.
Okay, stand on your.
MRI of the lumbar spine, no findings. AMG, severe compression of the right peroneal nerve above fibral head, which is something what we, let's say, would expect. Ultrasound, nerve edema on a compression of the region of fibular head right. MRI of the right knee region, nerve edema in the region of the fibular head, also slight subcutaneous tissue edema in the same region, all in the fibular head. MRI and ultrasound, no signs on high sciatic nerve lesions. Brain MRI, CT, and CT angiography, normal findings. During preoperative examination, the evaluation preparation for surgery, within blood analysis, elevated blood sugar about 30 millimoles per liter was noticed. It was completely first sign of diabetes to the young guy, 17 years old. Never ever knows about diabetes and never ever has some kind of confirmation or blood analysis regarding diabetes. So it's first clinical appearance. So we consulted the endocrinologist and introduced insulin therapy and endocrinological evaluation, as well as preoperative and intraoperative endocrinological treatment started immediately. and immediate preoperative blood sugar level within physiological, let's say, appearance, since we before the surgery decreased the level of the blood sugar level, and then neurolysis with fibrous resection proximally from the fibula, slight compression, decompression of the entrapment in the fibular head region, significant compression in region of the fibular head and distally, then complete the liberation of peroneal nerve and these branches with complete failure and signs of completely signs of the compression of the peroneal nerve.
I ovdje je već vidio difference dosta in the color of the slip mistaken.
And postoperative day 1, early signs of some kind of contraction appears. Sugar blood level normalized, insulin therapy ongoing, and the ecological treatment continued. Immediate postoperative transfer to the neurological department was performed, and early physical therapy started, and continuous physical therapy recommended. So we'll see what will going on, but this is a short presentation which might be stimulated for further discussion. Thank you very much for your attention.
Thank you, Lucas. Thank you. Really excellent to integrate with the case. And I don't know, shall we consider discussion with the questions from the participants? We had 3 presentations, one about anatomy, one about the bio, I would say, of the drop, and then diagnostic workup and management.
We have a few questions and answer, questions in the chat for questions and answer. You can see on the screen. Please, can you go for these questions? There are 2 questions and 2 comments.
Okay, so I'm trying to read.
It is a chat.
Okay, so we have an anonymous attendee that asks, isn't the difference in gluteus medius weakness the main difference between L5 radiculopathy and common peroneal nerve neuropathy? Then we have, so I would ask Crescenzo if he wants to reply about that, or anybody of you. I mean, we have.
Yeah, I'd happily say something about that, Deborah.
Yeah, okay.
So I think from the, just testing gluteus medius on its own is obviously very difficult. What we see on EMG is when the glutei are sampled, we see that's positive in L5 radiculopathy. But generally, the answer to this is in the history and examination, because it's mostly a mechanism of history that gives you the answer to this. Common perineal nerve, for difference between common perineal nerve neuropathy and radiculopathy. It would be my interpretation of that. So I would always, if there was a doubt about that, I would always want EMG. I don't know what the other panelists think.
If I may say my opinion, I mean, I don't think we can simply make such a straightforward question and say other than gluteus medius, other, I mean, neurological examination is much more complex and thorough. So it's not just one muscle that can be the difference between a presentation related to a problem in the spine and a presentation which is more distal.
Completely agree.
Thomas, what would you like to say?
Well, it's a very popular question for the American boards. So usually the answer is, and of course you're totally right. You cannot restrict it to one muscle group. But the one thing is you have to look for the tibialis posterior muscle, which is inversion. So if that is weak too, it's not a common perineal nerve lesion. Then it's more a higher lesion, an L5 lesion. That's a frequent question. So always look for your inversion. That's one
That's
addition.
true. And That's true, and this is actually the reason why, for instance, if you perform a tibialis posterior transfer that had a foot drop consequent to an herniated lumbar disc, we know that sometimes you do not have the criteria to give indication for that kind of procedure. But again, nevertheless, it's not so simple and not so straightforward. And as Michael correctly said, it's not just related to assessing one muscle. It's about what was the clinical history of the patient, if the clinical manifestation was acute or chronic, progressive or whatever. So it's much more complex scenario than what the question of the attendee was actually focused on. Fano? Yes.
Yes, what Thomas said is usually right. So the tibialis posterior, in my experience, is one of the muscle which guide you to the diagnosis. But I found cases of lesion of L5 with normal tibialis posterior.
Of course.
I think also what Dr. Fox said, that gluteus medius can help with electromyography, and the combination of clinical and EMG can help to differentiate. I just want to remind you about the neuropathy, the idiopathic neuropathy of the common peroneal nerve. The last slide showed by Maria Pedro was of the group of Rome with Luca Padua. He's one of the leaders of the Italian group of the common neuropathy, spontaneous. For instance, people put on a severe diet, for instance, they lose 40, 50 kilos in 1 or 2 months, they develop a complete common peroneal nerve palsy. Myself, I am intimately convinced that apart from the cases with cysts or trauma of whatever compression, the true entrapment does not exist. Of course, it is a personal opinion. Lucas showed us a wonderful case, but I think it was a diabetes. It was a neuropathy with diabetes. He was lucky because the patient started to recover the very first day after the decompression. But why should they have a fibrotic nerve? There is no reason. I think that many cases of so-called spontaneous idiopathic palsies are neuropathies that we don't know, but probably we surgeons operate too much on the entrapment of the common peroneal nerve. Of course, if there are some cysts, this scenario changes. Of course, it's a different thing, then it is a true entrapment. But it is a narrow passage in every patient. When you open a normal anatomy, normal common peroneal nerve, you find a narrow passage before the trifurcation. So I want to just call you for this because there are many, many cases of idiopathic neuropathies that we overlook and think to treat with surgery. Thank you. I've told too much.
I fully agree with Stefanos' discussion.
Okay, so gentlemen, I think we have to go on with the program and then maybe we can resume the discussion later on if we have time. It's my pleasure now to call Dr. Andreas Demetriadis from UK that is showing us that wonderful Scottish landscape behind his shoulders. And now you are going to mesmerize us, not just with the landscape, but also talking about foot drop in spine pathology. Please, Andreas. If you can share your screen and start your presentation, thank you so much.
So thank you, Deborah, for the kind invitation, and hello to all esteemed colleagues on the panel. Have the task of talking about the spinal relevance to foot drop, and I hope you can see this. Is that okay, Deborah?
Yes, perfect.
Right, so I have no disclosures. I'll make a small introduction, share a scenario. Anna will throw a couple of polling questions just to get us in the mood. I will then talk about acute bilateral foot drop and finish with some thoughts and probably more questions than answers. So in terms of foot drop for the non-peripheral nerve neurosurgeon, we all know this is typically defined as significant weakness in ankle plus or minus toe dorsiflexion. There's a variety of surgical and non-surgical differential diagnoses that we should never forget. It is a disability which can affect activities of daily living, and especially in the elderly, it provides an extra risk to more falls and more injury, and therefore its management is something we all need to improve on. I will share with you this case of a 45-year-old teacher who presents with a 2-month history of sciatica and a 2-day history of painful foot drop in the absence of any systemic disease, neurological disease, or diabetes. So it was clear that there was a combination of radicular pain plus foot drop. On examination, she had right ankle dorsiflexion weakness 1 out of 5 on the MRC grading scale. The EHL, extensor hallucis longus, was only 2 out of 5, and there was a combination of partial sensory loss in right L4 as well as right L5 territory. So if Anna is listening, can we go with the first question, please?
Absolutely.
And Anna, if we can see the answers of each question before we go on, we should give
Yes,
it no more than, I don't know, 20 seconds each. Is that?
Yes, even more,
Yes.
because I see that people are still voting. So let's give them another few
You're
seconds.
in charge. Tell me when I can keep talking.
Absolutely.
The answer is yes.
So the reason behind that question is because, at least in my environment, there is a debate as to whether this is an emergency or not. I just wanted to canvass colleagues from different scenarios.
Yeah, people are still voting.
Andreas, you're talking with a disc herniation.
Yes, clear disc herniation, pressing the
Clear,
L1.
yes, clear disc herniation, it depends, but I say yes.
I think we all agree that it has to be a yes.
Okay, I'm publishing the results.
Okay, good. That's good, because that's now a basis for question number 2.
Yeah, shall I launch it right away?
Yes, please. Now, I made a little bit of a blunder here in that I gave you the MRI result. But imagine that this is a patient attending accident and emergency. So question number 2, please. So this is a patient now, same story, but we don't have an MRI. It's sciatica for 2 months, foot drop for 2 days. It's painful foot drop, no diabetes, no systemic, no neurological disease, and clear weakness. When would you do the MRI?
Same day.
Same day.
Same day for me as well.
This in an ideal world, because
yes. Well, I have a,
let's go on talking about ideally. Yeah.
I like Stefano's disclosure. I also disclose I don't live in an ideal world.
Okay, let's wait 10 seconds more and we will end polling. I see that people are still voting.
I think we have to acknowledge that it's easy for us to sit and judge in retrospect, but in real life, there's a variety of opinions. And once Anna gives us the answer, I will. Okay, so we all agree same day. I can tell you for a fact that this patient was sent home and presented a week later. But let's move to question 3.
Just to remind you, Andreas, that Andreas Romero sent you a message to a chat that you should not ask tricky questions.
I'm trying to be as simple as possible.
Yeah, okay. Just
okay. This for me is a very important question because the evidence is not so strong. It's mainly based on expert opinion, which means level 5, and therefore.
Yes, Andreas, I would say if you were the patient and if you fear of medical legal issues. This would be a different answer.
Indeed.
But assume that we are ourselves the patients.
I agree with that, and that's why I put it there. But I still think we're going to get a variety. Realistically, my question is realistically, when would you offer surgery, if at all?
Now, immediately.
I think it's considered. I think it's considered an urgent procedure. It's an indication for urgent surgery.
For this case, I mean, in the very same day, MRI, very same day surgery.
Can I add something? The German guidelines from the neurologists, the interdisciplinary guidelines, they actually say if it's below 3 out of 5, then it's an emergency. So if they sue you and it was a 4 or still a 3, you're good. And if it was below 3, you're not good.
Anna, what's the answer here?
I'm launching the results.
Okay, so we have a small variation, which I think is realistic. Also, I know from discussions in other circles that some people would not operate and would give it a chance non-surgically first. And is there another question, a final one?
You mean complete palsy, complete foot drop?
No, as you can see on the screen here, it was foot drop, no anti-gravity power.
Yeah.
Yeah.
So M0 or at least M1.
It was 1, yes. Anna, is that the end of the questions, Anna?
Yes.
Okay, thank you. So I guess what I wanted to show you is that we all think we have the facility to do urgent surgery, urgent MRI and urgent surgery, but it's not necessarily always the case. So what's the anatomical chain? Well, theoretically, any pathology along this chain can cause foot drop. We have, of course, patients that have foot drop because of a stroke or multiple sclerosis, but pathology can be anywhere down the route of cord, roots, plexus, nerve, root, peripheral nerve, and myopathy. I'm now shifting a little bit to bilateral foot drop, where we need to consider endocrine causes, such as thyroid disease, diabetic peripheral neuropathy, other diseases such as anorexia and Crohn's, which can put them into the nutritional category. If you go into the neurological chain, anterior horn cell disease such as motor neuron disease or neuromuscular junction disease with myasthenia gravis can cause bilateral foot drop. Then we have peripheral demyelinating disease such as Guillain-Barré, myopathies, and anything in the chain. But the point of this is that these are gradual onset. They don't suddenly become acute foot drops. Common causes of bilateral foot drop in the past have been related to positioning of non-neurosurgical patients such as urology, gynecology, colorectal surgery, and that is a peripheral cause at the fibular head. But I wanted to contrast that to acute bilateral foot drop. We all know acute unilateral foot drop is a rare clinical presentation, but acute bilateral foot drop is even rarer. And most common reports of acute bilateral foot drop are due to bilateral common peroneal nerve palsies, especially iatrogenic positioning, almost of any other specialty. But the acute bilateral foot drop with spinal etiology until recently only had 6 isolated case reports until we found another series that I wanted to share with you. I don't expect you to analyze that in detail, but effectively there is a variety of discogenic problems, either in isolation or in combination with pre-existing stenosis that we had in our series. And also you can see that the levels were not only L4-5 or L5S1 or L3-4. It was quite a variety of levels. So that brings the question, what innervation is the dominant? And we all think it's L4 and L5. Therefore, that would mean that our clinical expectation would be that the posterolateral disc protrusion at L3-4 or L4-5, causing an L4 or an L5 lesion, or indeed a far lateral disc protrusion at L4-5 or L5S1, which would affect the L4 and L5 again. But let's not forget, acute far lateral discs bilaterally are not common. EMG studies have shown some amount of nerve fiber recruitment for L2 as well as L3 and down to S1 and S2. And then our series has proven that this fiber recruitment is supported. Out of the 7, we had 1 at L2-3, we had 3 at L3-4, which was the commonest. I'm not surprised by this because L4 is important for ankle dorsiflexion. Some colleagues were. There was only 1 at L4-5, which I thought was a bit surprising. And there was 1 at L5S1, 1 case at 2 levels. So the majority of both our cases and those in the literature align with expectation. However, the learning point here is there is definitely some unexpected disc level pathology. And the question is, could this come from aberrant innervation? So the flow chart is very simplistic. I don't expect anyone to be amazed here, but this is a very simplistic way of thinking. If there is acute bilateral, if there is bilateral foot drop, the question is it acute or chronic? If it's chronic, it's most likely to be a medical, non-surgical cause. If it's acute, the question becomes, does it come with Kodak-Wana syndrome or not? And in our series, 3 of the 7 also had Kodak-Wana syndrome. If it is, it's clear because it's spinal, MRI, and act on it. If it is not with Kodak-Wana syndrome, and if there are no upper motor neuron signs, then again, question, could the history explain common peroneal nerve palsy? If it does, the investigations will be different. If it doesn't, again, spinal. And if there are indeed upper motor neuron signs, the imaging will obviously be not just lumbar spine. So the issues, when Deborah asked me, what are the issues of spinal pathology and foot drop? These are the key questions for me. We always ask, is this painful or painless foot drop? Because we think painful means there's a better chance of recovery. Is there much evidence behind that? The answer is very difficult to find any. We all know it anecdotally, or we think we know it, but there is very little to find. The second question, is there any evidence that the timing or the duration of symptoms at presentation is relevant? The answer is yes. I have a couple of slides to explain that in a second. The next question, okay, most of us as surgeons would offer surgery, but how confident are we that physiotherapy cannot achieve the same? And of course, the last one, is there an ideal timing of surgery? I have discussed this many a time with colleagues who think definitely within 24 hours or 48 hours. I personally would try to do this within 48 hours at the latest, if it's an acute painful foot drop, ideally within 24, but I have also done it within 7 days and within 6 weeks. And the question is, what are the predictors of surgical success? Very poor literature, all of it level 3 to level 5. One of the few recent papers is this one from Japan. They've identified prognostic factors for drop foot in relation to lumbar degenerative disease. Out of 40 patients, they managed to find that age is a predictor. That's straightforward, I guess. Preoperative muscle weakness or strength was a predictive factor, and indeed duration of foot drop. And they said that surgery within 2 months can still improve postoperative outcome, which begs the question, right, so when do we relax and when do we rush? A similar conclusion from an American study of 70 something patients. I don't want to go into the details, but if you look again, age was not a predictive factor in this group, but preoperative muscle weakness was a predictor, and indeed the duration of the palsy was different. And in this time, they allowed up to 6 weeks between symptoms and surgery, and it was relevant. So it's not clear when the optimal timing is. We all feel that if a nerve is under threat, the earlier the better, but the evidence behind all this is very poor. So to summarize, I can say that acute foot drop has a variety of etiologies. Spinal etiologies are uncommon. They can both cause unilateral, bilateral foot drop. Unilateral is commoner, but still rare. There is still, in my opinion, controversy amongst neurosurgeons as regards the role of surgery and its ideal timing. The few predictors that are consistently identified in the very few studies are the age of the patient, the duration of the symptoms, the preoperative weakness, and indeed the time of duration of symptoms at the point of surgery. I think there are more questions than answers. This is never going to be a subject of a randomized control trial, and that's where hopefully collaborative multi-center prospective projects might give further answers. So thank you again for your attention. Let's not forget that hopefully you can visit us here, but certainly in Hamburg.
So Andreas, thanks so much. It was really a very nice presentation. I really enjoyed it so much. And I think also all your questions are probably going to trigger a very lively discussion at the end of this mini session. So the next topic is going to be definitely very interesting because we are going to talk about the occurrence of foot drop in iatrogenic injuries. And it's my pleasure to ask Thomas Kretschmer to start his presentation.
Can you see my screen?
Yes.
Okay, perfect. So also my thanks for the invitation. Actually, I could make it very short because a lot of aspects have already been alluded to, and the answer is yes. Iatrogenic drop foot does happen very frequently. If you look on the right, this is a view on the sciatic nerve that was cerclaged in a 16-year-old girl. Here you have the look in a popliteal fossa where the nerve was torn after removal of a sharp drain. Here we have the case that we had before. Benign schwannoma was excised with the nerve. And here you have a tortured sciatic nerve where the perineal part was completely out after cementing the nerve. So, excuse me, that was one too fast. If we only talk about drop foot, there's a lot of possibilities for etiology. So, of course, we are mainly talking about nerve, so we're focusing on acquired peripheral neuropathy. But if, and Deborah alluded to that, if we think more in the direction of function, there's a lot more of work that could be done by nerve surgeons and neurosurgeons. We already talked about spinal stenosis, but there's also the case for stroke and cerebral palsy. If we talk about iatrogenic drop foot etiology, of course, the bulk of it is due to spinal surgery and tumor surgery, due to procedures of orthopedic and trauma surgery. And not to forget, this is the stuff that you learned in med school, the old and classic stuff. Due to malpositioning, splints, plaster of Paris, K-wires. But to me, there's a sort of a new entity, and these are endovascular procedures. This is just a short summary. Don't go in the details. Just a few, starting with a very old paper, a few entries into the world of iatrogenic foot drop. And what you can see here, apart from the well-known things like excision of a skin mass, hemilithotomy positioning, spinal anesthesia, more and more case reports of only a few cases, but about endovascular treatment, for example, after popliteal artery laceration. Even there's a case about a iatrogenic pseudoaneurysm of the superior gluteal artery that had been treated with embolization, and especially can have, if you use liquid embolization with glue, for example, sometimes you can get severe lesions to the sciatic nerve, and the most sensible part of meaning the most vulnerable part of the sciatic nerve always will be his perineal part. And the other whole block has been nicely described already with the previous talks, but there is a more recent considerable paper from the Toronto group of Dr. Failings, and which is a meta-analysis of a lot of studies. And just to sum it up, the average rate was 9%, and the mainly divided up under anterior lumbar underbody fusion, lateral lumbar underbody fusion, and posterior decompression and fusion, screw malposition, 11 deficits. So whoever is interested, that's a nice paper. If we then go a little bit lower down and then leave the spine and we go to the perennial nerve, the series of Dr. Klein is always a good reference. And if you see on this table, there are 276 perennial nerve lesions, and 20 of them, which makes up to 7%, had been iatrogenic. And if you look on the ones operated, 183 had been operated in total, and 9 of them were iatrogenic. So these were made up for 5%. If we look on our own quite old series from 20 years ago, if we look on all the iatrogenic nerve lesions, then the number 1 was spinal accessory. If we would go by common perineal, superficial perineal, and deep perineal, the common perineal as such already would have been number 2. If we take all this as perineal, the perineal nerve would have been number 1 damaged nerve. What you can see here are still common lesioning mechanisms: osteotomy, removal of Baker cyst, vein stripping, very popular, muscle releases, hip arthroplasty, meniscectomy, and also removal of plate, ligament repair, and also, of course, tumor removal. If you look at the newer paper from Gregor Antoniadis, you will find the common perineal on place number 4, which makes up place number 1 for the lower extremity. So the next question would be, okay, you have an iatrogenic lesion, how you treat it? You treat it as any other nerve lesion. And maybe this is an addition to Maria's very nice presentation about imaging. I find this paper is quite useful if you're not so much used to interpret the images. If you just think about 4 different levels. There's that one femoral level where the peroneal nerve and the tibial run behind the biceps femoris, and this corresponds to picture number 1. Here you have the biceps femoris, and here you have the peroneal and the tibial nerve. If you go to level number 2 at the femur condyle, you see the gastrocnemius, the biceps, and still the 2 nerves. If you then go to a fibular, to a fibular head level, you will find the common peroneal nerve, and with the 1 and 2 asterisks, you find the peroneal muscle and the tibialis anterior group. And then the last level is the famous neck, where the common peroneal turns around. And here it's a little more tricky, because you could already find the trifurcation, and sometimes, as in this case, you could also find the articulate branch. This is more difficult to interpret, because at this point the nerve turns around and makes a more horizontal run. So nice paper from, and it's free, from 2013 from the same paper. I'm not going into the details, but it's always a good idea to have an early MRI, because you already can see acute signs of denervation within 2 weeks, like here in the tibialis anterior muscle and the extensor digitorum longus. Here we have the nice case, and these are all normal MRI images, not as exquisite like the one Maria has shown. Here you find a contusion with quite a substantial swelling of the peroneal nerve that can be appreciated behind the fibular head. And also for other reasons, this image is quite nice, because this points to a fatty atrophy. And this is important to know, because if there's fatty atrophy, there's no more muscle that you could re-innervate, for reason number 1. And the second reason why I find this very nice, because this is a paper from not an unfamous university, and they describe again what has been told before. This patient underwent a resection of a schwannoma at a more proximal level in the sciatic nerve. So this means that happens not so infrequently. And of course, as we have seen before, especially in the peroneal nerve, a high frequency nerve ultrasound imaging is quite valuable. What you see here are separate fascicles in an axillary view, and this is the longitudinal view. Actually, all of this is the peroneal nerve, and this is a post-operative follow-up of a split nerve repair. So this is distal fascicular distal fascicles, proximal fascicles, and those are the grafts. So this is work of Christian Heinen, and we will later see the actual patient. So if it comes to diagnostics, I think EMG is very helpful. And of course, I'm not going into detail about the clinical exam, which is of utmost importance. But EMG can help you to decide, is a lesion complete or is it not complete? And when it comes to the peripheral nerve, so those are questions that you probably will have to answer. How long will you wait if there are some signs of reinnervation? And sometimes you have a reinnervation in the superficial peroneal nerve, and a deep peroneal nerve, which supplies the tibialis anterior, is totally out and will never come. So then it would not be a nice idea to wait forever. So it's also important, what signs of reinnervation do you see? Are these limited only to the peroneal musculature? And another interesting thing is if there is any electrical activity at all, also meaning pathological spontaneous activity. Because if there's none anymore, this could be a sign for change of muscle into fibrous tissue. I will not go into the details because we heard about that before. But I think when it comes to the foot drop, it is very important not only to think about nerve, but to think about function. And then you very quickly come to what is a normal gait. And you've seen in a variant picture this image before, the stance and the swing phases. And it is the same as before, which is the classification from Rancho Los Amigos, which you actually see here. It's not so important to go into the detail, but it's nice if you think about what tibialis anterior, extensor digitorum longus, and hallucis longus actually do, and when they start to work, which is actually in the swing phases and during the loading response. It is, if you try to find something about power of these muscles, it's actually quite difficult. This is a very old paper from the late 80s that tried to give you the relative strength of muscles. And I find it quite interesting that actually for the tibialis anterior, you do not need that much of power. It's almost the same as the tibialis posterior, which tells you that the tibialis posterior is an excellent muscle to substitute for the tibialis anterior. So if it comes to procedures, I think we will hear more about that. So this is just to remind you that it's not only about nerve decompression, repair. There's also the point for split graft repair. And I think these can fare a lot better. Then about tendon transfer, about functional electrical stimulation. And if you also think about stroke, and this can be a role for a neurosurgeon as well, neuro implants. You see one here. This is supposed to be for stroke patients, where you actually get not only a stimulation for the perineal nerve, but also for the upper muscle groups. So just to underline some of the points, we already had seen cases about tumor removal. So there, I think the question would always be dependent on the level. Would you go via reconstruction, or what is your prognosis for reconstruction, or would you go with a transfer? Then we will look at an iatrogenic sciatic nerve lesion. We quickly look for a full perineal nerve lesion and a partial perineal nerve lesion. So first case, here you see how the patient is positioned on the operating table. You look directly here on a partially sutured sciatic nerve, and those are the threads of a hip prosthesis. So this is an aged woman that had a progressive sciatic nerve palsy during several weeks, cutting her sciatic nerve from lateral to medial, meaning the perineal nerve was completely out first, and then slowly the tibial nerve was affected as well. And due to the prognosis, it was quite clear that we, by nerve reconstruction, as you can see here, cannot do anything for or against the foot drop. But this woman had severe pain. So it's not always about function only, but also sometimes against pain. And I'm a strong believer in grafting if there is pain due to partial nerve lesion. This is another case. Very young female had a complete perineal nerve lesion Unfortunately, she never found a physician that told her that you can do something against this. And because she was out for a long time already, she was operated with a tendon transfer, and this is already the small video after the operation. So I think we probably hear about the variations of tendon transfers. This is just one, again, a paper that I, because of its descriptive value, find quite nice, describing the bridle technique. And this is actually the patient that whose nerve you saw in the ultrasound. So he had a complete foot drop as well. And there was only the deep perineal part destroyed. So we went for a split graft repair, and this is the postoperative result. So I think sometimes these split repairs, they can fare better than a complete grafting of the whole diameter. So to sum it up, iatrogenic drop foot is quite frequent. Personally, I think early action is required. Apart from clinical exam, imaging and EMG are of utmost importance. And the good news is, if you combine a few methods, functional improvement is possible in a few cases, maybe not in all. And personally, I think pain on its own can also justify graft repair. Thank you.
Thank you, Thomas. Thank you so much for your interesting lecture. And we are going on, and now we are going to talk about the occurrence of foot drop in lumbosacral plexus injuries. And it's my pleasure to call Stefano Ferraresi from Italy to talk about it. Stefano, please.
Yes. Can you show the screen? Can you show?
Yeah, we can see the screen. Just put it on the slideshow, please, Stefano.
Yes. So thank you very much, Deborah. You organized very well this meeting.
Thank you.
I remember with pleasure that when you were with us, we referred to you as the queen of the foot drop. This was a joke, of course, but it reflected your interest for this very important issue. So this is a series of lumbosacral plexus just to show you how the vast majority are those lesions with involvement of the sciatic nerve. Also, the initiating cause is a car accident. It is relevant also the motorbike, but also working, falling from a height, and also iatrogenic injuries. You can do a classification with a chart like in the brachial plexus, and it is very important to try to localize the lesion, anticipating where is the problem. The question is the basic problem. Despite what Andreas Dimitriades said, in my experience, L5 is the leading route for the foot drop. I don't have so many cases of L4 involvement in discal herniation. Almost all cases are L5. The question is that the damage of L5 can interrupt a few or more or many axons directed to the common peroneal nerve. The site can be the common lumbosacral trunk with the upper arrow or the lateral part of the sciatic nerve. There are three levels of damage which can give a foot drop: an avulsion of L5, a damage of the lumbosacral, and the lateral part of the sciatic nerve, usually brought about by the rupture of the posterior wall of the acetabulum. Of course, you have to make a diagnosis of L5 avulsion. Some clues are when you have a gluteus like this one, because you have probably another nearby avulsion of S1, and you have to try the diagnosis with very in advance, not to feed illusions in the patients. So an MRI, a 3D MRI, or an angio CT can give the answer. Another indirect sign, which is very helpful, is the presence of the Trendelenburg sign, which is the incompetence of the medial and maximum gluteus. And this is another indirect sign of possible L5 avulsive injury. If you are sure, if you reach the certainty, idea of the certainty of L5, there is avulsion, there is no point in waiting. You can, of course, wait a little bit, but you should strongly consider a fusion, which can be very helpful to the patient instead of waiting an impossible recovery. To have a clues of a lumbosacral trunk injury, you have other signs. A reconstruction like this one with the posterior wall of the acetabulum and also of the iliac wing can be a clue to a damage in this area. Also, if you have a plate in this position, can be another clue, but you must exclude any root avulsion, because if you don't have any avulsive root of the L5, you may expect some recovery in these patients. Also, other clues are an open book rupture or a pelvic fracture like this one. These are other clues of no avulsion and only of the lumbosacral trunk injury. Other clues are a severe dystrophia of the foot, a simple lateral part of the sciatic nerve. Usually, there are exceptions, but usually has a nicer appearance of the foot, not a very dystrophic foot, not a discoloration or a hypercoloration like this one. If you have an L5, as I told you, as also Thomas told us, you have a weak inversion. So you have a very weak tibialis posteriors, and this happens in 95, I would say 98 cases. I have only a very few cases with normal tibialis posterior, and in this patient, you could perform a tendon transfer with success. This is another clue when you have a posterior wall damage of a sciatic nerve injury, especially in the lateral part, which is almost indistinguishable from the common peroneal nerve injury. Of course, hamstring muscle can make the difference, but this should be done in EMG, not clinically, because there is no difference. And I suppose also in EMG, if I have to see how many mistakes in the diagnostics in EMG I see every day. Many people with damage of the sciatic nerve who are labeled as common peroneal nerve entrapment or injury, and consequently, I will show you also operated. Sometimes you have to ascertain and go to the report. There are surgical reports which are written very well, and in some of them you can find the rupture of the sciatic nerve. Of course, this is another question. It's not only a compression, a traction, also the expectation of recovery is different. So please always ask for the surgical report after a posterior wall fracture of the acetabulum. Clues of the simple sciatic nerve is a normal aspect of the foot. You have, of course, the palsy. Rarely you may have an incomplete injury. This is very rare, but it can happen. And normally you have a tibialis posterior, which is strong, has a good inversion, scores M4 or M5, and is suitable for a tendon transfer. This is what happens usually, contusion of the sciatic nerve. This is more or less what happens in the hip displacement, especially in the second or third surgeries. There can be pain, algodystrophy, of course. This can be the same presentation of the lumbosacral trunk, but it is less often. This is, of course, what happens with the hip replacement. And I see that many cases, we have an answer on EMG with common peroneal entrapment. And also we have some exceptions, some problem. Look at this case, you may have a damage of the median gluteus, and this can happen during the Cocker-Langenbeck procedure, which is the standard incision to repair the posterior wall of the acetabulum. Sometimes you see the red arrow, the superior gluteal artery and nerve, which innervate the medium. So you try to think the reverse. The superior nerve innervates the medium and the inferior innervates the maximus. It is a game of memory, but it is very useful. And in this case can be a damage of the surgical part. During the Cocker-Langenbeck, you have a big damage because this patient has no avulsion, just the damage of after the surgery. You see here the superior gluteal nerve. This is a nice anatomic wax of the Museum of Florence. And this is a very dangerous part, not only for the gluteal artery, but also for the possibility of an inadvertent damage of the superior gluteal nerve. Then there are always some people who think to be more intelligent than others. We say this is a proverb in Italian, that the mothers of the imbecile are always pregnant. And this is what happens. We have near our neurosurgical department, another neurosurgical department with the colleague who is the most intelligent of everyone. This was a complete damage of the sciatic nerve. It was necessary to read the surgical report, and this doctor did a decompression of the common peroneal nerve. I have no words, I cannot say anything. Deborah knows to whom I'm referring to. What is very important when you have a damage, remember that there is a very delicate balance between flexor muscles, which play like a lion, and extensor muscle. And this happens under normal conditions. And what happens during the night, when you have a full 9 hours with the extension of the foot below the blankets, you have a retraction of the Achilles tendon, and it is very, very important to make a prescription of this device, which is called a dictus, and the aim is to keep the foot at 90 degrees during the night. This is very important. In the last 3 years, I use for hip injuries or lumbosacral trunk injuries with spontaneous recovery this artifice, and I have reduced by half the necessity of tendon transfer of the tibialis posterior. In about half of these cases, I don't do any transfer. It is just enough to do an elongation of the Achilles tendon. So this is a very important trick. It is an experience that we didn't share with Deborah because she left and went to Emirates. But I invite everybody of you in the cases where you can anticipate a spontaneous recovery, or you have a good recovery of the flexion part and no recovery of extensor, to use this artifice. It will reduce dramatically the need for tibialis transfer. If it is the case, of course, you can do a tibialis transfer. The result is very nice. If you, we do the transfer just connecting to the bone, not to the other tendon. Of course, can be done also to other tendons. with the modification shown by Thomas, but enough to the bone, the result can be really excellent. You do a tenodesis and shortening tenodesis of the extensor hallucis and the extensor of the digitorum. So I remind you the importance of the foot, of course, but it's nothing to do with the brachial plexus. They share with the brachial plexus the possibility to reinnervate only the proximal muscles, and this is a common finding in brachial and lumbosacral plexus, but the big difference is that the arm, the noble part of the arm is the hand, and the foot is not the noble part of the lumbosacral plexus, because with an arthrodesis, still with no motion of the foot, you can go on with the almost normal life. So thank you very much for your attention.
Thank you so much, Stefano. I mean, no need to say that, of course, I share whatever you said, because I mean, we are the same school, right? So I think these were very interesting presentations, and now we have some minutes for discussion. Would some of the panelists would give a comment about what we heard so far, or shall we ask somebody from the floor? Okay, so here there is a question from Galib Atameme. What about iatrogenic injuries due to intramuscular injection? I don't know if Thomas wants to say something, otherwise I might comment on that. Thomas, you are muted. Thomas, you are still muted.
Sorry, I did not hear the beginning. I just heard injection.
So the question was about iatrogenic injuries due to injection, to intramuscular injection.
As far as I know, they are not as common anymore. They were more common in Africa due to vaccinations, and they were common when the wrong IM injection was used. Injection injury in general, very difficult to handle. The most or one of the more devastating things are probably crystalloids. If you used cortisone, and the other thing but that has nothing to do with perennial nerve, is in addicts that you, I think heroin on nerve is very devastating. I had one case like that.
Okay, so if I may add something, because relocating in the Middle East actually gave me a completely different perspective of etiologies. So when I was living in Europe, I think I have seen altogether probably like 3 foot drops consequent to a sciatic nerve injury after injection, submuscular injections. But coming to the Middle East, and also because I have traveled a lot in countries like, for instance, Pakistan or India, it's actually much more common than what you might expect, because submuscular injection in these countries are very often given by unprofessionals. And also we have to consider that there is also a different type. Many patients are absolutely thin, very slender, and therefore no bulk to cover the sciatic muscle. Now, the first thing that I think I would like to highlight is that the injury is basically a chemical injury. A lot of people still believe that the problem is related to the needle giving an injury to the nerve. This is actually a secondary problem. It's not the needle entering the sciatic nerve that causes the problem, but it's the chemical injury to the nerve. Now, the literature says, and also the experience says, that in these cases, you should actually advocate for indication for surgery as soon as possible. In cases where you have a complete foot drop, a complete sciatic nerve palsy after the injection, it is said that you should go for surgery even within 24 hours. And the treatment should be a neurolysis. Normally we talk about external neurolysis to relieve the nerve from the adhesions, the scarring and fibrosis after a chronic process. But in the specific case of these injuries, because it's a chemical injury, you should go for a external neurolysis and also internal neurolysis. Probably one of the very few selected cases where internal neurolysis is not detrimental, but can actually be of advantage. I do hope that I replied to the question. Any other questions about the presentations that we heard about iatrogenic lesions or about the lumbar sacral plexus injuries? Okay, so let's see something else here. So
there is Mariano asking something about for Thomas, I think, about the suture. Dr. Sokolovsky about the suture of the common peroneal nerve. He wants to be consolated because the results are really very poor, and this is true. One of the first questions by Mariano I saw.
I cannot find it. Where is it? Because I am reading the questions and answers, so
I'm just not sure if there's a whole presentation about that. That's why I left that out. Wow.
If Mariano is hearing us, I think that we can consolate him. The results, in our experience, are very poor, but mainly depend on the type of injury. A clear-cut, a clean glass injury of a blade injury can be repaired with very good results, especially in a direct suture. But for instance, very extended.
If I may say, actually, that would be something that I'm dealing with in my presentation in a few minutes.
Sorry. So
I would avoid to go into details in that, and that's let's focus on something else. About lumbar plexus injuries. About lumbar sacral plexus injuries, any more questions? Any of the panelists would like to comment on that?
Maybe just the point that I already made, that I think sometimes it's not only about function, but sometimes you have, in partial injuries, you have devastating pain. And I believe if you do a graft repair, at least sometimes you have a better chance to ease the pain if the axons can sprout again, even if you don't think you can do, for example, something for the peroneal nerve function.
I usually try to avoid to do a graft if I don't have any hope of recovery. I start as a first thing the electrostimulation, a proximal electrostimulation, but sometimes I agree with you, also can be attempted to graft a severe injury. But in my experience, this never happened. Only in gunshot, of course, yes. But otherwise, not in hip replacement damage or lumbosacral trunk, because also grafting is very difficult. They had packing in the pelvis. They have a devastating injury, so it's not so easy to go there to perform a graft, especially if they have some residual function.
But I agree. But the point sometimes is, and I mean, you showed the pictures, and frequently you even have fragments of the fracture in the nerve, or you have metal in the nerve. And these
yeah, in that case, you have already found the cause of pain. So just remove and make a clean the nerve, and eventually to do a split or a repair. This, I agree with you. I mean, but with nothing, just fibrosis and cutting and making grafts, I had no experience with this.
Okay, so I think it's time I introduce myself, and I proceed to my presentation, which is going to be about foot drop in common peroneal injuries. So before I start, I would like to tell Michael that I'm just briefly mentioning tendon transfers, and of course he is going to be the one that is going to be the icing on the cake at the end of this webinar, and is going to extensively to talk about that. So we definitely have to say that foot drop related to common peroneal nerve injuries is a rather frequent pathology that we can see in neurosurgical practice, because these are the most statistically frequent nerve injuries of the lower limb. Now, the clinical presentation is that of a foot drop, because we have a denervation of the peroneal muscles that provide foot eversion, as well as denervation of the tibialis anterior and the extensors for the toes. In order to avoid the problem of the steppage, we usually recommend a foot orthosis. Now, this is one of the orthoses that are usually mostly recommended, which I consider is absolutely uncomfortable to wear for the patients, and many of them develop sores. And it also actually impairs plantar flexion. So what I recommend to my patients is also Dictus, and Stefan already showed this kind of device before, and I think it's actually the best one in the market. Now, talking about the site of injury, a common peroneal nerve injury may occur at the knee or the ankle, although some others also would include as a CPN injury those injuries that mainly or predominantly affect the lateral component of the sciatic nerve. Anyway, statistically speaking, common peroneal nerve injuries are particularly common at the knee, and this is also related to the peculiarity of the course of the common peroneal nerve that runs around the fibular neck and then is tethered distally. When we talk about the etiology, we definitely have a wide spectrum of causative mechanism, but musculoskeletal injuries are by so far the most common ones. Now, a number of bone fractures dislocations seem to be related to the occurrence of a foot drop due to a palsy of the common peroneal nerve. Some are actually kind of rather uncommon, like for instance, tibial plate fractures are associated to a foot drop apparently in 1% of cases based on dates of the literature. And the most frequent injury that is related to the occurrence of a foot drop are knee dislocations. There are complex ligamentous injuries that may be associated with simultaneous vascular and neurological injury. Concerning the latter, the presence of a common peroneal nerve injury with the knee dislocation varies from 4.5 to 40% in the literature. With Stefano, when I was in Italy, we had quite a large series of patients treated for common peroneal nerve injuries after knee dislocations, and we found that about 85–90% of these patients really presented extremely severe nerve damage. Now, a situation that is less known is the occurrence of a foot drop consequent to a common peroneal nerve injury at the ankle. These are considered extremely rare, just sporadically mentioned as case reports in the literature, but it's likely they might be actually underestimated. There are some new papers that actually claim that probably up to 15% of all grade 2 and 3 ankle sprains may be related to such occurrence. A common peroneal nerve injury due to a lesion at the ankle may be acute, and this is usually the consequence of a sudden forceful elongation of the nerve, might be also resulting from a compression related to the formation of hematoma. But sometimes we also have lesions that might be delayed and because the trauma triggered the formation, for instance, of an intraneural ganglion cyst or neuromuscular alterations that might result in various pathology that ultimately are responsible of a chronic ankle instability. Now, if you have a foot drop after an ankle sprain, if you have a complete foot drop, usually this is something that happened because there was a forceful inversion in an already plantar flex ankle, and the traction applied to the overstretched peroneal muscles also involves the common peroneal nerve, resulting in an ischemic injury and therefore the onset of the common peroneal palsy. Thomas already spoke about iatrogenic injuries, and I would like to briefly remind that procedures like, for instance, total knee arthroplasty or arthroscopic lateral meniscal repair are described in the literature to be associated with the occurrence of a iatrogenic foot drop. Yet we can also have patients that will present such event after they have been put in a very tight plaster, giving compression of the common peroneal nerve at the fibular head. And we should not forget malpositioning related to positioning in the OT. And also in patients that have been bedridden for very long term. Before, when I talk about when I presented the slide about the causative mechanism, I also mentioned penetrating injuries and gunshot injuries. And in addition to the direct damage related to this kind of etiology, I'd like also to emphasize the possibility of an uncommon complication that is related to the development of a pseudoaneurysm of the popliteal artery that will be clinically manifest as a pulsatile growing mass in the popliteal fossa and a progressive deficit of the nerve. Now, whenever we have an injury, always we try to sort out which are the lesions that are going to be reversible or those that will advocate indication for surgery. So it has been calculated that about 20% of CPN injuries present spontaneous recovery. And the most consistent, the most relevant prognostic indicator is the clinical presentation immediately after the injury. So if the patient presents an incomplete palsy, then we have chances equal to about 80% that there might be a spontaneous recovery. Otherwise, if the patient presents a complete palsy of the CPN, the chances for a spontaneous recovery are definitely reduced and to 38%. There is also a correlation with the length of the segment which has been damaged. Therefore, we have seen that traction and compression injuries on a segment of the CPN shorter than 7 centimeters are more susceptible to spontaneously recover in comparison with longer segments. And also, if we make a comparison between the rate of spontaneous recovery for the terminal branches of the CPN, we will see that the deep peroneal nerve has a less favorable outcome in comparison with the superficial nerve. Now, what happens if we do not have a spontaneous recovery? In closed injuries of the CPN, we usually have a wait and see approach for a few months. Usually I would wait up till 4-6 months. And then in that case, we will give indication for surgery. Now, when we talk about surgery, we know that actually the strategy has been kind of rather controversial in the literature. And there is the debate about submitting these patients to a tendon transfer or a nerve repair. Now, tendon transfer seems to provide an excellent recovery of gait, immediately resolving the steppage with high satisfaction of the patient. And just for the good old times, I am putting this little video clip of a patient with a tendon transfer that Maria and I did in Günzburg about 4 years ago. Now, this is the reason why the Russian and the French orthopedic school, they particularly advocate the tendon transfer. Yet, we cannot avoid to mention that to reconstruct the common peroneal nerve certainly is much more favorable, because the anatomical reconstruction restores both the sensory and the motor function, and this ultimately results in a better stability of the ankle. Now, but why do we have such a big part of the medical community that seems to be so reluctant to accept the indication for nerve repair, and they prefer to directly advocate palliative procedures? It has already been mentioned during the discussion. The truth is that if we review the literature, it seems that there is a high rate of failure of nerve repair of the CPN. And this has been attributed to several reasons, like, for instance, the excessive length of the nerve or its close proximity to bone surface. But we certainly consider that the hypothesis formulated by Hanno Millesi at the end of the 80s certainly the most adequate one. There is a force imbalance that is established after a CPN injury between the denervated anterior compartment of the leg and the posterior part of the leg, which is still functioning. So this is why Hanno Millesi advocated that a good strategy might be to associate the nerve repair and the tibialis tendon transfer at the same stage. So the point is now, what do I presently do? What are my guidelines for this kind of patients? Now, my choice of the surgical technique is actually, I would say, customized, if I may say so. And it depends on the referral date, the surgical findings, and also the age of the patient or other, factors related to him. So just a brief mention of the fact that, because, as we said before, in CPN injuries consequent to ankle sprain, the etiology is that of an ischemia. Therefore, there is no anatomical interruption of the nerve. Those are those cases that I will directly give indication for a tendon transfer. But what about others? So if the patient has no pain, because I consider that always an absolute indication for exploration at the popliteal fossa, my strategy at present is the one describing this algorithm. If the patient comes after 1.5 years, I will give indication for a tendon transfer. If the patient is referred to me within 1 year elapsed from the traumatic injury, I will go for exploration of the common peroneal nerve, and then based on the surgical findings, I might decide whether I just have a nerve repair or I will associate the nerve repair with a tendon transfer. So the surgical approach is a posterior approach, and as we can see, the surgical findings are definitely a remarkable variety. So how do I decide what I will do based on exploration? Now, there are some cases where I would decide to go just for nerve repair only. And these are those cases where I could do a direct suture or a split repair. I have to say I did a direct suture just in a penetrating injury once, and 3 split repair, and they were also penetrating injuries. So very few cases. And then if the gap in between the two stumps of the CPN in case there has been a transection is shorter than 5 centimeters. So talking about iatrogenic injuries, this was a case I operated 2 years ago here in Dubai. She was a Filipino lady presenting a schwannoma of the CPN operated by an orthopedic surgeon that just resected the schwannoma and the nerve. The patient went out of the OT that she had a complete foot drop and was in severe pain. And I reoperated her 2 weeks later and did the nerve graft. And she has no tendon transfer. After the procedure, she was completely painless and she has recovered quite well. But if on exploration, I see that the graft required is longer than 4 or 5 centimeters, then I will certainly associate also a tibialis transfer. So then I have the nerve repair, the graft repair, plus the tibialis tendon transfer. In some cases, I might decide that the lesion is deemed not suitable for a nerve repair. For instance, when the graft has to be longer than 13 centimeters, or for instance, if the patient is an old one, and I will just go for the tendon transfer. Now, talking about the postoperative outcome, we have seen that the causative mechanism impacts on the outcome. Sharp injuries are definitely those with the best functional outcome. They are followed by CPN in knee dislocations, but other forms of causative mechanism seems to be less favorable, and gunshots are definitely the ones with the worst prognosis. Concerning functional recovery after we have done the nerve repair and the tibialis tendon, we have to say that the patients are usually highly satisfied because they can immediately recover a gait without stoppage thanks to the tendon transfer. And then, following regeneration of the CPN, you will have recovery of the peroneal muscles, the tibialis anterior, the extensor digitoris longus recovers later, and a recovery of the extensor hallucis proprius is kind of rather unpredictable, and unfortunately sometimes it's a failure. This is to say thank you for your attention, and this is a picture of Madina Al Saleh, which is an extraordinarily beautiful archaeological site in Al Ula in Saudi Arabia. Thank you for your attention.
Thanks, Deborah. Excellent presentation. I will just congratulate you for the presentation and to all speakers. Now, please continue with the webinar.
Mm-hmm. So now the next presentation is going to be Nora Dengler, and she is going to give us a presentation about foot drop in intraneural ganglion cyst. Thank you, Nora.
Hi, good evening, everyone. Thank you very much, Deborah, for the invitation. Thank you very much to the group and to the other speakers for a very, very lively and good webinar so far. So for the next 10 minutes, I will shortly talk about foot drop and ganglion cysts. And thanks to Deborah for giving me that topic. And I know this is a topic that not everyone likes really much. So I will give my very best to bring it close to you in a way that you may like and that you can imply in your daily practice. There's a little fight with my computer, I'm sorry. Not able to. So there's nothing to disclose. And despite one thing, I've been to the Mayo Clinic in 2016, which may have an effect on the choice of articles that I refer to. And the outline of the next 10 minutes is to talk about diagnosis and diagnostics, classification, treatment, as well as outcome in ganglion cysts. So diagnosis and diagnostics, when do you have to think about a ganglion cyst? Of course, when you do have a peroneal nerve lesion. And if this is sure, either by clinical exam or by electrophysiology, and you may have a cystic mass, which may occur in the ultrasound or the MRI, you should think about a ganglion cyst. And in the MRI, it is classic that you are not going to have any signs of contrast enhancement. And there are some nice signs, the tail sign, the transverse limb sign, and the signet ring sign. These are only a few that may help you to have the diagnosis ganglion cyst set up. So differential diagnosis, of course, includes other tumors of nerves, nerve tumors like schwannoma, sarcoma, myxoma, or even Baker cysts. This is especially a specific of specific interest in that location. And here there are some nice examples of ganglion cysts in MRIs. And this is a sign that is referred to as tail sign. So you can see here that this may be a body of whatever, and this is the small tail that shows the connection of the articular branch of the perennial nerve to the joint here, to the fibular joint. And you see here very nicely that this is a U sign. So you see how the articular branch runs in the tissue, and this is referred to as U sign. And when the nerve runs, or when the cyst runs a little bit different, a little bit more on the side, then it may be referred to as J sign in the MRI. And this is a so-called signet sign. So when you see here that the cysts pushes away the fascicles around, and you see the epineurum here, if this is an interneural cyst, then this may look like a signet ring, and this is what is referred to as signet sign. So classification of ganglion cysts, especially close to the peroneal nerve, can be done by location. So you can refer to the carrier nerve, so where the cyst is located. This could be peroneal. This could also be tibial. And sometimes you even have cysts that go up to the sciatic nerve, so before the bifurcation. And a major and relevant classification is the relationship, the anatomic relationship to the nerve, which carries or which is affected by the ganglion cyst. So this can be extraneural, you can see that here, but it also can be intraneural. And of course also by origin. And we have to say that for a long time, it was not clear what the reason for ganglion cysts is, but the perennial nerve is, I think, the predominant nerve who's affected by ganglion cysts, and this is the reason, which is nicely seen here. So the trifurcation of the perennial nerve includes the articular branch, which comes from the superior tibiofibular joint. And if you do have, this is the close connection. So when the articular or the synovia from the joint has a connection to the articular branch, then the fluid can come up here in the branch and even go back into the peroneal nerve and up here to the sciatic nerve, depending on what amount of fluid is produced in here. So by origin, that could be a superior tibiofibular joint. This is the most common one for the peroneal nerve, but of course for other nerves, there are a lot of other joints that can be the reason for ganglion cysts. I think this is widely known. So treatment, and this is something that I want to put an emphasis on, as when I was trained, I was already proud that someone told me, oh, you have to ligate the articular branch to prevent that a recurrence of a ganglion cyst occurs. So it is not only the decompression of the nerve, but it is also the prevention of the recurrence. And I think this is really a tribute that I want to give to the Mayo Group, because they have been hard years' work of collecting data and making up intellectual concepts, how this can be prevented. And this is, I think, somewhat the result. And I later on also show by outcome that this is effective in prevention of ganglion cysts. So what they do is they do perform a U-shaped skin exposure here. They also perform a U-shaped fascial opening at the proximal end of the fibula, and they dissect the CPN articular branch here. So this is easily seen here. And then they perform, of course, assist decompression. This is an important step to decompress the nerve, to give him the chance to recover on a functional basis. And then the articular branch needs to be ligated. So this is what I was told. I think this is a classic interpretation, a classic treatment that most of neurosurgeons do perform. But what the Mayo group somewhat not invented, but they propagated it, that the partial resection of the joint needs to be performed combined with the synovectomy to somewhat cure the reason why the articular branch always fills with the articular fluids. So the outcome that they reported is quite okay. They do have an intermediate time follow-up of 40 months. They show that from preoperative dorsiflexion of 2, the patients recover to a grade of 5, that the median eversion recovers from a median grade of 4 to 5. And so most of the patients do recover, but they do have radiologic recurrence in 9% of patients in that time. This is not always combined with the clinical recovery, clinical recurrence, but this radiologic recurrence is mostly extraneural. So by cutting or ligating the articular branch, the recurrence is not intraneural, but by resection of the joint, we can say that it is not always the possibility to prevent any occurrence of fluid that comes out of the joint. So 9% has to be, is realistic in their data. So to summarize and conclude, please, everyone, think of ganglion cysts when patients with foot drop present to your clinic. It can easily be diagnosed. For a first overview, you of course can perform an ultrasound, but I think the MRI and the signs that I did show you are very, very nice for differential diagnosis, and you can easily identify ganglion cysts with the MRI. And I want to make an impact on the surgical techniques that is going to be performed by you. Please perform the decompressive surgery, but with preventive techniques. So the branch ligation, as well as the STFJ joint resection, as I presented. Thank you very much.
Thank you, Nora. Thank you so much. This is actually a very interesting topic. And I would like, for instance, Stefano and Lucas to comment, or anybody else. Lucas?
Thank you. This is something which is a very important issue, not very frequent, but generally speaking, we have to be aware of that. And indeed, if it's nicely operated and on time, operation should be nice results. Even if it is, let's say, few weeks or up to 2 months foot drop, I have some nice results with foot drop recovery following the operation of the intraneural ganglion cyst. So, I mean, the main thing is to recognize it and then to refer to the specialist.
Yes, Michael, do you have any experience?
I see a reasonable number of them, and we definitely go along with Rob Spinner's technique of ligating the recurrent branch. I think one of the interesting presentations that we sometimes see is that you get patients who say that with activity, their foot drop gets worse. And I think that's a direct pumping effect of the intra-articular branch pumping into. And because it's on the deep perineal branch side, often disproportionately in the initial stages, the deep perineal section is more affected. So you'll see some patients where they seem to have relatively better preserved superficial peroneal nerve sensation and even motor function early on. And we don't personally resect the tibiofibular branch, but I think the intra-articular resecting and tying off the branch is important. I don't mind if they get a ganglion cyst coming back. It's actually very common to see a ganglion cyst in that space. As long as it's not in the nerve, I don't really mind. So, yeah, I entirely agree.
I have a comment on that, just a brief, Nora. I had an intraneural ganglion cyst and I perform it like spinner, and I make a ligature of the ramus articularis, and now the same patient has more distally an extraneural ganglion cyst compressing from it outside. So how can we explain this? You know, I mean, I can go again. Sorry?
Did you resect the joint?
Joint branch.
Did you resect the joint? I mean, not the branch.
No, not the joint. I don't do the joint. It's more.
I didn't do it, and I did it
not at the joint.
In the early years. I didn't do it in the early years, but lately, I think in the last 2 or 3 years, I do it.
In some circumstances, we resected even the joint branch, sensory branch, and the recurrent branch, and make some not opening of the joint, but make some let's say suturing or the place where the branches are going to the joint, and to close this foramen completely. And so far, no recurrence.
Leandro, do you have any remarks about that? You are supposed to
yeah, just okay. I'm just taking a look what the other participants talking about, and I agree. If our opinion is it's very important to ligate the branch, and we have few experience to have operating just 2 or 3 cases. In most of them, we found not large cysts, but small cysts. And the ligation of the articular branch was resolved the symptoms and avoided the recurrence.
I also confirm the same thing as Michael Fox, same. I would say the same thing in a worse English. Only thing it is worth doing always the ligation of the articular branch, because you may have the surprise of very nice recoveries. And those who recover a little bit less are only the deep peroneal branch cysts. But the ligation must be recognized early when you have a foot drop or something like that, a beginning foot drop. Investigate the knee and the area of the upper third of the leg and go to the ligation. You have the surprise of wonderful recoveries of the foot.
Okay, so I think we can now proceed, and we have the 2 last presentations. I'm really sorry to say that because I'm really enjoying this webinar, I have to say. So it's a great pleasure for me to have my friend from Brazil, Leandro Preto Flores. Especially, yes, it's you. And is going to talk about a topic which has been really very controversial. And this is I called him because he is the one that is really going to say what we can know about nerve transfers in foot drop. So please, Leandro.
Yeah, this is always the same. Every Congress, I have to talk with the most controversial issues. It's always the same. Let's try. I'm going to talk a little bit about treating foot drop with nerve transfers. That's, as Deborah said, is a very controversial approach to this dysfunction. And of course, I'll not try to complete talk about everything. I just talk about a few issues about this theme, and trying to answer quite simple and practical questions about this type of approach. The first one and the most interesting is, what is it? It's very simple. It's a technique of nerve transfers that is proposed to reinnervate the tibialis anterior muscle by the reinnervation of the tibial peroneal nerve or the tibialis anterior motor branch that are branches from the common peroneal nerve. So here we have our recipients. Most of the literature talk about tibialis anterior motor branch and deep peroneal nerve as the recipient of this nerve transfer technique. So if these are the recipients, which are the potential donors? The review of the literature, so we can find that the superficial peroneal nerve, it can be used for instance, but most of the time, the branch from the tibial nerve are more frequently used. Of course, you not use the entire tibial nerve for the nerve transfer, but branches from the tibial nerve, for example, the medial head of the gastrocnemius, lateral head of the gastrocnemius, soleus branches, flexor digitario longus, flexor alluxis longus, proximal or distal branches, and even fascicles from the tibialis nervus also after an intraneural dissection of the tibialis, the tibial nerve. The literature, a systematic review of the literature shows that the most frequent use branches as donors are the soleus branch, the flexor digitario longus, and the flexor alluxis longus. These are the most frequent reported, but all of the other branches have been already described before. Which are the indications of this procedure? This procedure can be used for injuries of the lumbar roots, sciatic nerve, and peroneal nerve. In case of isolated peroneal nerve injury, especially for traumatic injuries, for those cases in which reconstruction is not predicted to observe good results. In cases of grafts, when you need grafts longer than 6 centimeters. This systematic reviews and meta-analysis of the literature regarding this nerve transfer showed that this is the most common, showed that this technique has been employed for reconstruction, for recovery of common peroneal nerve, sciatic nerve, lumbar root, or lumbar plexus, but not only for traumatic injuries, but also for iatrogenic and tumor resection and following tumor resections. So another question is, which are the surgical techniques currently available? There is a lot of different techniques available and described in the literature, but I'm going to show you the two most frequent reported. I'm going to show you the transfer of the soleus branch to the deep peroneal nerve as described by us in 2013, when we approach both nerves via a posterior approach, and the branch to the soleus is transferred to the deep peroneal nerve after a dissection, intraneural dissection of the deep peroneal nerve from the superficial peroneal nerve into the common shelf of the common peroneal nerve. And then the deep peroneal nerve is transposed in direction to the soleus branch, allowing a direct and tensional suture. The other very frequently described and very often used technique is that described by the Mayo group, especially described by Juve, and which the target is not the deep peroneal nerve, but the tibialis anterior motor branch. It's a much more super selective transfer, in which the tibialis anterior motor branch is the target. One important thing that we must talk regarding this approach is that different from we usually found in textbooks, the tibialis motor branch is not a direct, in most of the cases, not a direct branch from the deep peroneal nerve, but it branched especially from the common peroneal nerve or from the articular branch. So you must, when you approach, when you decide to use this nerve as a target, you must remember this tricky of the anatomy in order to choose the proper recipient. So for this technique, usually the approach is a lateral approach, and when you dissect and identify the tibialis, the branch to the tibialis anterior muscle, and by means of intraneural dissection and by means of interfascicular identification of the fascicles to the flexus hallux longus or flexus digitorum longus, or both, we can do the transfer directly to the recipient by an opening on the interosseous membrane, which allows to decrease the distance in a tensionless suture. Well, now I showed you which are the recipients, I showed which are the targets and the donors, and how to do it. Usually, now we must, when I say, is it works? Why we should do this technique? Because we have other techniques that works maybe better, like tendon transfer. So to say if it works, we must review the results, which are the results that we have in the literature. In 2019, it was published systematic review and a meta-analysis of the 5 most larger clinical case series that treated with this issue. And this meta-analysis showed that only 50% of the case can achieve results as M3 or M4. So, and it's a bimodal, if you see this graphic, it's a bimodal distribution of the outcomes. You have half of the patients as responder and half of the patients as non-responder. Some of the papers have very bad results, poor results, just like ours, and some of them very nice results. But since 2019, we have seen in the literature an increased interest in such technique. We have found papers from China, papers from Australia, Iran, again from Australia, and these new papers brings some novelties about the outcomes that we can expect. I prefer to show you the outcomes in terms of this table that is a little bit different from that from the meta-analysis. We included some of the classical papers and the novel one, and the techniques, regardless the kind of donor or regardless the kind of recipient, usually we can find 30 to 50% of recover as M3 or better for ankle dorsiflexion. So you say, is it good? I don't think this is as good as a posterior-tibial tendon transfer, but in cases very difficult to treat, like lumbar root injuries or very high sciatic nerve injuries, in which you have a good donor as a powerful branch from the tibial and no other possibility for reconstruction, I think this is a possibility that you must have as your armamentarium. And finally, so if you don't have so much very nice results, how can I select the patients for such procedures? This is an unanswered question, but the studies that try to address this kind of problem identify that, of course, younger age and earlier time for surgery good factors for better results. But this is good for every kind of nerve surgery. For me, the most important issues that determines better or worse prognosis are the low energy of the trauma, especially regarding the knee, trauma to the knee. If you have high energy trauma to the knee, you're gonna have very bad recipients, so the result will be compromised, of course. And it's very important to check the quality of the recipient. We know that isolated peroneal nerve injury seems to recover better than proximal injury, for example, high sciatic nerve injuries, but only in those cases in which there is low energy trauma. And another important factor that affects prognosis is the quality of the donor. The donor must activate an M5 response in the respective muscle in order to achieve at least M3. If you don't have M5, if you have M4, it's not enough. And this is why some cases of root injuries and sciatic nerve injuries may respond worse than isolated peroneal nerve, because you never know if the tibial nerve is really normal to this kind of transfer. I think this is very, I have only 10 minutes, and I think this is all I have to say. There's a lot more to say about this transfer, especially about rehabilitation, but in 10 minutes, I think this is all that we have to say. Thank you very much, and thank you for your kind invitation, Deborah and Lucas.
Leandro, thank you so much. I think in spite of the short time, you really gave a very comprehensive, exhaustive review and made probably this technique much more familiar to all of us. So the last presentation, but definitely last but not least, is related to tendon transfers. And we are going to have Michael Fox to talk about that. Tendon transfers, as we mentioned before, are an essential part of the repair strategy for foot drop, and definitely we are looking forward to hearing from what Michael says.
Thank you very much, Deborah, and thank you, Lucas, as well. So I wanted to, I'll just go to the first one, sorry. So I thought I'd kick off with saying that obviously we talk about foot drop, but the vast majority of the things that we see are have an inversion deformity as well. And so it's not just drop down, it's twisted in. And that's one of the reasons why moving the tendon, the deforming force, in this case, tibialis posterior, in this chap with a knee dislocation, does two things. Firstly, it removes the inversion deformity as well as correcting the foot drop. Obviously, the treatment options that we have in terms of tendon transfers vary by the indication. And if you look up tendon transfers for foot drop, you will find that every person here will have a different technique. But there are some common factors. You heard Stefano say that he puts it into bone. You heard Thomas say that he puts it onto tendon. I think the important thing is that you need to have a technique that works for you, and you'll need sometimes to have, because of these different indications, you will probably need to have at least two different ways of thinking about it. For example, if you have, if your cause has been knee trauma and or a tibial or fibular fracture, it may not be possible to pass the tendon through the interosseous route, and you may be obligated to go the circumtibial. And conversely, if you've had extensive scarring or surgery on the medial aspect of the lower leg, it may not be possible to use the circumtibial route. I'm going to talk primarily about tibialis posterior tendon transfer, but of course, in some particularly neurological reasons for addressing foot drop, you may be using the peroneus longus or even other alternatives, depending on the spinal cause or in progressive neurological deformities. And with that in mind, I would also say you need to be 100% sure that your neurology is stable. The other thing, and the most common reason that we have for treating foot drop, is common peroneal nerve injury at the time of knee dislocation. We always want our knee surgeons to stabilize the knee. It is almost impossible to rehabilitate a tibialis posterior tendon transfer in the presence of knee ligament injury and an unstable knee. So we tell them, get on, do your knee reconstruction first, rehabilitate that, and then we'll do the tendon transfer. The other thing to say about that is, in the presence of tibial or fibular fractures, there must not be a limb length discrepancy, because it just won't work. So we talked about that. I agree with Thomas. We tend to assess by, if there's doubt, obviously not in the simple common peroneal nerve injury, but if there's doubt about the viability of the transfer, we will also use an MRI scan to look at the quality of the muscle. So you can see there the tibialis posterior looking more denervated distally, for example. So in terms of the different techniques, interosseous, circumtibial, I'm going to just talk through what I think might be useful in terms of the tips and tricks and the things that we see that make your life easier as an operating surgeon. The one that I tend to use, as long as I'm using the circumtibial route, will be through onto the tendon. So I will do a circumtibial onto tendons. You need to have, obviously, the passive range of movement. You're donor powered. The single most important things are your patient needs to be in for the operation, prepared to do the therapy support, and doing it without an adequate therapy follow-up is just surgical vanity. So this is I'll show the circumtibial posterior tibial technique. I always recommend putting unless the patient happens to have a fall into quite extensive external rotation, I always put a sandbag under the contralateral buttock, because that will allow you access on this side. I'll mark out the tendons you see here from medial to lateral, tibialis anterior, EHL, and the extensor digitorum. If they have hypermobile MTP joints, then be very careful putting the tendon transfer onto EHL and EDL without first attaching it to the tibialis anterior. I like to put it onto the EHL and EDL because the patients like it. They like the fact that they put their feet into their shoes and their toes don't curl up. What about taking the tibialis posterior tendon off? Does that cause a problem with secondary flat foot? No, probably not. When you take it off, you may or may not have a sesamoid bone underneath it. Before you deliver it to the proximal wound, take the sesamoid bone off. It will be much easier to do that. The superior border of the posterior tibialis posterior is always easy to find. The inferior border, you'll have attachments that pass through, of course, onto the metatarsals. You need to make this border yourself. I tend to leave some attachment from the navicular onto the metatarsals because I think if there is a concern about instability, that should lessen that worry. When you're making the medial incision, I tend to go close to the tibia. You may have to release, in terms of getting a straight line of pull, you'll probably have to release the digital flexor. But you can see my fascial cut is almost on the tibial border. That you can see delivering out. This one did have a small sesamoid bone here. This is the tendon has been delivered through the proximal wound. You will find when dissecting the muscle belly back, you may have an accessory muscle. You may have a distal neurovascular bundle, which you can safely resect, as you'll find that the main innervation is much higher up. You can stimulate if you wish to find it and check. And if you need to sacrifice part of the pennate muscle, that doesn't matter. This is where the external rotation is important. You will find that your assistant tries to retract the tibial bone, which is not particularly useful. And you need to have a reasonably extensive approach here if you're going to use the interosseous approach. And if you do that, I advise you to make a big window, because otherwise there's a risk of it fibrosing up and your tendon transfer ceasing to work. I tend to mark the top of the tendon, deliver it through onto, template my incision on the dorsum of the foot, and then close the, you can see with a reasonably straight line of pull, and then find the top. The cutaneous nerves may or may not be relevant depending on the cause. They may or may not, but I tend to sling them and mobilize them. Find the relevant tendons, put them on, stay sutures. And then using this blunt tendon passer, you make your tendon passage. In this case, you can see that there's a reasonable muscle bulk. You can either make the hole bigger, or you can, this is, because it's a pennate muscle, this section of muscle is not going to work anyway, so you can, it's too bulky there. You can resect some of it, that's okay, it still works. I tack it onto the top on the back, close these wounds, take out the bolster so that you then have a better line of pull. And at this point, this is where you need two assistants. I put a bolster under the knee, and that's to take the pressure off the gastrocnemius force pass across the knee joint. And that allows your assistant to better dorsiflexion. And then in this case, I'm passing through tibialis anterior onto, and if you need to pass through tibialis anterior, in this case with metatarsophalangeal joints quite flexible, then pass it through this, have one person pulling proximally in the line of pull of the tendon and distally, and I would fix onto EHL and EDL before finally tacking onto that. And the reason for that is if you tack it onto tibialis anterior and then attempt to tack it onto, to pass it in a pulver-tough manner through EHL and EDL, it's very difficult to get the tension right. So pass it through and fix the tibant last, and then you can get the tension right. But frankly, it doesn't matter. You need to have, everyone needs to have a different technique. You can put it onto the bone, you can put it just onto tibialis anterior, you can put it all the way through onto peroneus tertius. This is just the, whatever works for you. So then you may, if your assistant has been pushing adequately, you may get a reasonable position. But they need to then, I mean, I've taken the pressure off this, but then they need to hold it for the rest of the operation. And then you close the dorsal wound and put it in a plaster. We put it in a below knee plaster and make sure that we are all the way down, including the toes. This stays on a back slab for 2 weeks. Then we put them in a full lightweight plaster of Paris, non-weight bearing, up to 6 weeks. And then it's out initially into an air cast boot, and then therapy, minimum 6 weeks. In terms of activities thereafter, I always warn them that we've taken your inverter, put it on the top of your foot. You are going to be unstable on uneven ground. So cutting movements are going to be difficult, but straight line running should be fine. So this is, this gentleman sent this to me last week. I did him a couple of years ago. And you can see that there is still critically, there is still some slight inversion on that. And what's most impressive about this is his ACL reconstruction, frankly. But it is possible. You have to tell them not to go back to football or rugby or position or sports where they change direction, because they will suffer an inversion injury. But straight line running, you can do. So I've not gone through the peroneus longus, but I've just shown the tips and tricks really. And I don't think I have anything else to say about it. Thank you.
Thank you, Michael. I think it's really enlightening, especially for a lot of neurosurgeons, because I mean, the panelists here, we are all aware of the fact that you need to know tendon transfers if you want to do peripheral nerve surgery. But unfortunately, we have to say this is not so much in the mindset of the general neurosurgeons. And so this is why your contribution was definitely important. Now, the last two presentations, I think, are probably going to trigger a lot of questions from the floor, because, I mean, they were definitely very stimulating from the intellectual point of view. So anybody of the panelists would like to comment? I don't know, Maria, would you like to say something? Stefano, you have a remark?
Yes, I have a question for Michael Fox. You told us that bone or tendon are the same, but I was really impressed by the result of the last patient you showed running on the grass. You had, because with the bone, the problems are always the extensor hallucis and the toes, and you had no detachment of your suture. So you are very happy with the tendon to tendon suture.
Yeah, I would say I warned them that there is about a 10% risk of either stretching out the transferred tendon, or if they invert, if they manage to go over on their foot, what they tear off is the extensor digitorum longus attachment. So I always warn them there's a risk of that, and I give them up to 10%. I think in my series over the last decade, it's been about 5%, but I always go slightly more pessimistic. And in those circumstances, you can open up the dorsum and retighten and reattach it onto the tendon mass. So that's what I do. I think for our pediatric orthopedic colleagues, they like to put it onto the bone because they worry about the relative position of the toes with growth. And I totally understand that. But for me, I changed to this, and I don't use, Srinivasan described splitting the tendon and putting it through. And I don't tend to do that, although the people who do that report really good results. And the only thing which I didn't mention is if you split the tendon, the argument is that you shouldn't split it more than 10 centimeters up, because if you do, there's a risk of propagating and then you lose your tension. So, but the patients like this. I would say for the general neurosurgeon, learn this, because God knows in peripheral nerve surgery, you have enough operations that have miserable outcomes. This one is great. They do really well. And they, as Deborah referred to, they like it. It's a good immediate result. And, I'm always careful about the activity, but I have one patient who sent me a picture of him finishing the London Marathon. I would not advise him ever to do that, but that goes back to what Thomas said about the relative power of tibialis posterior. It's a good muscle, it's a good transfer.
And how often you need to elongate the Achilles tendon or the flexor digitorum profundi?
Okay, so in those circumstances, because I don't do that so often, I always get in this case, one of my pediatric orthopedic colleagues to do that, because he does that all the time for CP for other reasons. So if I have an indication where we need to do that, I always do it with one of my colleagues, just because he does it more. I know you have experience, Stefano, but I don't the same way. So not very often, because we're getting them after knee dislocation. They tend to be active, fit young people, so not often. And if I do it collaboratively. So.
Thank you.
Can I ask you a question?
Yeah, Thomas. Yes, please go.
So, Michael, when I understood you right, you primarily you go for tibialis anterior. So, and would you? I'm aiming at the inversion. Sometimes you get.
No, Thomas. I rushed through it. I apologize. I don't go for tibialis anterior. I actually go for extensor hallucis, as long as they don't have, they're not hypermobile. Extensor hallucis is my right rein. Extensor digitorum is my left rein. That's the balance I go for.
Okay.
I only put tibialis anterior into the mix if I have hypermobility at those joints, at the metatarsophalangeal joints. And I showed this case because this patient did. But normally, you can do it with just extensor hallucis longus and extensor digitorum in the manner of Srinivasan, and that works well.
So you don't bundle tibialis anterior and the extensors. You go primarily for the extensors.
Yes, absolutely, because I think it gives a better line of pull anyway, and they like it with their toes, and it's the so then you have the assistant pulling left. If you put stay sutures onto EHL and EDL and pull one, pull the other, one inverts, the other everts, And if you get that balance right, then you get a nice result, and they like that. And I suppose the other thing to say about peroneus longus, which I referred to but didn't show a case of, I never use peroneus longus if they don't have FHL, because your peroneus longus is your primary depressor of the first ray, and if you take that off and their flexor hallucis longus is not good, then they really hate it, because they lose their toe off on walking, and so if there's any doubt about flexor hallucis longus, I never move the peroneus longus.
What would you do in a case where you get a good lift, but you have too much of inversion? What would you add in?
Well, I mean, as I said in the talk, you can put peroneus tertius on, or you can do what you talked about with the with the bridle, right? I mean, I think you need to have multiple techniques available to you. The reason for going through the tips and tricks were to show the little things that I think make your life easier. And then I wouldn't, you can see there are 20 different types of tendon transfer that all work pretty well. So I wouldn't presume to tell people what to do. I'll just say, these are the things that have made my life easier in doing it,
So you would need, if you would use the perineal, if you would have more inversion than you like.
Sorry, in what sense? I would focus more on the lateral attachment if I found I was putting into inversion. Yeah. And there's also an argument. There's a good paper saying that there's sort of biomechanically and also clinically suggesting that the interosseous route gives you a better result in that respect as well. So, but it's another incision, of course. And if you think about the hand and upper limb, we're always told, don't stick the tendon transfer between the bones, but suddenly in the leg it's okay, So I guess they're bigger bones, but in the principle of tendon transfer is, you don't tend to pass it between bones because you worry about fibrosis. And in this case, obviously the end artery, anybody who's been there between the bones and not made it bleed spectacular at some point just hasn't done enough, I guess. Yeah.
Yes, but mainly the issue for the bones in the foot are the strengths which are in the game. And this is not the case in the hand. In the hand is enough tendon to tendon because they have different forces to be submitted.
I was operating with our foot and ankle surgeons earlier today, and I asked them with one eye on this talk. I just said, well, what do you do? Because they do it. And they, one of them, I think maybe on this, watching this because he wanted to see the technique, because he'd been using an interference screw to put the tendon into, I think he put it into the cuboid, and had several, a couple of patients where it had just pulled out because the bone wasn't good enough quality.
Oh, of course.
So, and that's the same sort of interference screw that they're using for anterior cruciate ligament reconstruction. So, they're strong, biomechanically strong structures. But I guess with those patients with foot drop, they may have a bit of disuse osteoporosis. They may not have the same strength of their bone.
Yeah.
So.
Other remarks?
May I have a question to Leandro, because I always, it is a wonder your results, because I must confess, I did 5 or 6 cases and I was very disappointed. So I set apart this experience, but after today, probably I will try again a second series, because I was so disappointed with the first one. And the selection, I think, was good. A very good donor, very direct suture, very good shape of recipient, no damage, no neuroma. So I am disappointed, and I don't know where is my mistake.
Stefano, I have the same opinion of you. I don't know if you take a look. My results were terrible. I published in 2013, only 20% of M3 or M4. So I also gave up. I have the opportunity to review 2 of the patients that we have lost follow-up when we published that paper. and one of them recovered M4 too. So I would say that from the 13 cases we've done, me and the group of São Paulo, Dr. Mário Siqueira, we joined our results for that publication. From the 11 cases that we have operated, we have only 3 cases of results considered as satisfactory, for example. But for this presentation, I have the opportunity to review some of the novel published studies about this technique. And it was a very, I would say, happy novelty for me that the recently published paper, especially for the guy from Australia and China, they showed very nice results. But from China was the same technique of us, and from Australia the technique as described by the group of Mayo. And what I can say to you, in my hands it was not good, but I think this is a technique that's evolving, you know. And maybe if you choose better the recipient, if you increase the number of axons by using, for example, 2 donors, maybe the results can be useful in some cases. The problem is, which are the patients who gonna benefit from the technique? No paper has answered that question, but I think we must try. For example, I was thinking in changing my technique. Instead of using the deeper nerve as target, to use the tibial anterior muscular branch and using the soleus branch, because the soleus branch has the largest number of axons disposable by, it was proved by axon count studies. So maybe you can try, maybe you can review our results, you can try again. And yes, for those cases.
Yeah, my selection in those 5 cases was in those patients where the graft was very, very long, more than 25, 30 centimeters. So I decided to, probably there were some tearing of the recipient. There was something wrong, because this was a selection. I never selected patients with the upper injury of the sciatic nerve with good internal compartment. And so I wanted to see the nerve cut, not just a not functioning nerve. Probably the not functioning nerve from lumbosacral injuries are a better candidate. I don't know.
Yeah, the problem of these patients is that we never know if the tibial nerve is good enough for a transfer, you know. This may be a problem with our outcomes, because we employed, initially we developed this technique only for high sciatic or lumbar plexus injuries. And in these cases, we don't know if the biochemical machinery of the nerve is good for reconstruction as it is good for neurotransmission. So maybe this was a problem, and maybe this is because isolated injuries of the peroneal nerve have demonstrated better outcomes than high injuries from the sciatic or the lumbosacral plexus, you know.
Okay, so you inspired me for the second go of this experience.
Yeah, you must review our technique.
Yeah, Leandro, can I ask you?
Okay.
If you do the nerve transfer, you'll think the selective transfer to tibialis anterior, and tibialis anterior, you get a good recovery. I've seen this in a patient a couple of weeks ago who came in and had a nerve transfer elsewhere. Great recovery, actually, to tibialis anterior. And it was for a common perineal nerve indication, not for anything higher up.
Okay.
So the issue that I saw with that patient, the reason he came was because he was inverting more. He had tibialis anterior pulling, which tends to invert on its own, and tibialis posterior as well, of course. So I suppose the question is, for that indication, would you tendon transfer as well? Would you do it anyway and look to supplement with a tendon transfer, or would
you mean at the same time? or in different times?
I think afterwards, because at the same, or even at the same time, I don't know, but you wouldn't really know the outcome, would you, neurologically?
Yeah, the problem of this, if you use only the tibialis anterior muscle branch, is that happens if the patient has no recovery of the superficial perennial nerve. So I think in these cases, if you must wait and see the result. If the result is good enough, you cannot use add a tendon procedure. But because you're gonna have the if you perform a tibial posterior transfer, you can decrease the power for internal rotation, and you can solve this problem. This is a good idea, yeah. But I never done this before.
Okay, good. Thank you.
Okay, so any other questions?
I believe not. Maybe some in the chats for question and answer or something like that.
Yeah, I'm having a look to see if there is anything. But I think we might actually consider that it's more or less all. I don't know, did you want to say something, Lucas?
Well, 3 hours and 15 minutes, almost full tension, full concentration, excellent presentations, and I would say excellent contribution to the education in this field regarding this particular topic. And thank you very much for participation in this ENS Peripheral Neurosurgery section series of webinars. Thank you, Anna and Eans staff for supporting us, for giving us opportunity to use this platform for organizing this webinar. I don't know exactly how many participants have been in the moment, but Anna will tell us later. Anyhow, I would like to thank you once again and to congratulate Deborah for excellent selection of the panelists and excellent creation of the excellent program. So I think that we can be all satisfied. And I would like to announce our 5th webinar for this half season, which will be devoted to the peripheral nerve sheath tumors, which will be on June 16. And you will, of course, receive all this relevant information and invitation. This webinar will be created by Christian Heinen, who apologized himself because of his new obligations in the new, as well. He started to work in a new position. So I think, Deborah, you can conclude. We can conclude this meeting and say, have a good night and nice evening.
Yeah, I have to say that I think that the sessions were definitely comprehensive. I think we tried to provide to the participants a rather complete overview of this this kind of problem and what we can do and how we can manage that. I would really like to say thank you to all the speakers, because I really must highlight that the presentations were really absolutely interesting. And thanks to all the participants. And if I may say so, living in the Middle East, tomorrow is the Eid al-Fitr, so Eid Mubarak to everybody. And I do hope that next time that we are going to catch up, all of us, it's not going to be on Zoom. I'm personally fed up with this virtual meeting, I have to say. It was so much better when we were just catching up all together. And let's meet soon again. Okay?
Lovely to see you all.
Touch.
So,
just to tell you that a screenshot was already made until Andreas was present. So we are all set, I mean, all done for this webinar. And I would like only to ask Anna to send us this screenshot. And thank you once again.
Thank you.
Thank you. Thank you very much.
Thank you all, guys. Thank you very much.
bye.
Bye-bye.